Sorry, I just got distracted because I thought there was a message. We will go straight into apologies. Joe Harrison gives his apologies, and I think everybody else is here, which is great to see. Any declarations of interest? No, thank you very much. And we then go on to straight up to the patient story.
Thank you, Alison. I have two of my lovely colleagues here who are going to present this. Before we get started, we're already engaged in quite a significant amount of work about revising our approach to patient stories. So what I expect you to see in the future is we're looking at mechanisms that we can purposefully articulate the patient's voice through them, rather than us presenting on their behalf. So we're looking at various different digital mechanisms, but also a framework about how we construct the patient story. In particular, I think recordings will be really helpful for us because these stories are incredibly important for our clinical teams, and they allow us to see it from the patients and their families' lens. This story may be slightly different to what we've had in the past. It does require us to listen to an experience where we could have done things better. And there's lots of learning that's come out of this. So I'm going to hand you over to the team who are going to tell you about what's happened. And I guess from my perspective, it's really important that we understand when we don't get things right, they can define the whole breadth of experience for the patient and their families. And that's what this is, a really good and interesting story to get our heads around. So Emma and Sharon, over to you.
Hi, good morning, everybody. So I'm Emma Coddington. I'm the Associate Chief Nurse now, but you'll see on here it says Divisional Chief Nurse, and this story does originate when I was in that role in surgery. So just to explain the difference. And this is Sharon.
Hello, good morning, everyone. I'm Sharon Robertson. I'm the matron for Patient and Family Experience. So really looking forward to sharing some of the stories that we've gained from contact with patients, hearing their stories and bringing them the patient's voice here to the board.
Thank you.
Okay. So this story is extremely close to my heart, obviously very involved with this family. And I am appreciative of the opportunity to tell the story here. And as Yvonne says, there is a negative slant to this story, but it's also very important that we understand looking after a patient holistically, what that absolutely means. So if you want to start the... So the gentleman I'm going to talk to you about is Richard Sherratt. And Richard was a 57-year-old, and I'm taking you back to 2020. So Richard came in December 2020, and for those of you that will recall what was going on in December 2020, it was a really, really tough time. And Richard did present in our ED with COVID. He'd been to the urgent care centre. He was a relatively well man. He had diabetes that was well controlled. Other than that, he lived a very healthy life. He'd attended the urgent care centre because he wasn't feeling too good with the COVID diagnosis that he had. His oxygen levels were in the mid-90s. So urgent care wanted him to be seen by our ED department, so he came down. He stayed in our ED department for about 3 hours. He had a chest x-ray, he had some oxygen, and his oxygen levels improved. He was given some antibiotics because that chest x-ray did show some inflammation in his lungs, but nothing that we were too concerned about at that time. And so he went home. He was what we call safety netted in the fact that if you just start to feel unwell, you do come back. And 2 days later, Richard did come back. Now, to add to this story, Richard had got COVID, probably from his wife, who was working at the time, and she got COVID first. They thought from the workplace. So I think that bit's important from the family's point of view. So Richard did come back 2 days later, and he had got a deterioration in his symptoms. We admitted him at that point. He went to Ward 2, which was, well, at the time, quite a lot of our wards were COVID. And he started to deteriorate in the way that we were seeing some people of this age start to deteriorate, especially if they did have a condition that might predispose them to worsening symptoms of COVID, like his diabetes. On a positive note, the collaborative working during COVID, the respiratory team and the ICU team worked very, very closely together. And every day we would talk through the patients that we were worried about. And Richard was one of those patients. Clinically, he was one that made you curious. He made you think the vital signs are okay, but he's not okay. It's not adding up. So we did transfer him to ICU for that monitoring. We didn't ventilate him at the time, but he was on our worry list. There was something about Richard that was worrying us as clinicians. He did really well in ITU. He was well looked after. He started to improve. And at that stage, we were looking at patients that we would use those ICU beds for those patients we really needed to. And so we would move in and out of ICU as we saw fit. And so Richard, on this particular day, his oxygen levels were good. He was mobilising around his bed space. So great. So hopefully he's on that trajectory of getting better. Although we knew with COVID, that trajectory was very unpredictable. So we moved Richard to Ward 15, our respiratory ward. He didn't get moved till later on in the evening, but this was a positive sign. And for the family who hadn't visited Richard in all of this time, he's been moved to the ward. He's doing really well. Within a few hours of moving to the ward, he wasn't doing very well and he deteriorated. And as a result, we did have to intubate and ventilate him on the ward and take him back to intensive care. Now, what we did with a lot of patients when that was happening and the patient and their relatives couldn't come and visit, we would use their iPhone or their iPad to make contact with the family and have a FaceTime call. And that's what we did with Richard. So he called his wife and we had that conversation. And I was there at that time with the anaesthetist. And then we intubated and ventilated him and we took him back to intensive care. He held his own for a bit, but unfortunately on Christmas Eve, Richard deteriorated and died. We got Linda in, his wife, on that day, and that was the first time she'd seen him since he'd been admitted. Very, very tragic. It was about 7:30 on Christmas Eve. The clinical side of Richard's care, we're very comfortable with, and although the outcome wasn't what anybody would have wanted, we honestly know there was nothing we could have done more. When Richard was transferred from Ward 15 back to intensive care, that transfer is very risky. So the focus is very much on the clinical safety of the patient. In COVID times, property was difficult to transfer, especially when the patient was COVID positive. We tried to look after that property and highlight that it was property belonging to somebody who was COVID positive. And our process at the time was to use red bags so that it was highlighted. For whatever reason, on this particular day, a red bag wasn't available. And all of Richard's property was put in an orange clinical waste bag. He was transferred to ICU. The property went up later on and was hand delivered. And when you get to ICU at the time, they've got, as you go in through the doors, there's like a foyer before you go into ICU. And because you needed to be fully in full PPE, the clinical waste bag was just popped inside. Because Richard was on ICU about a week before he died and he didn't have any visitors, the fact that we couldn't find his property wasn't recognised until Richard had died. We can only assume that property that was in a clinical waste bag was treated as clinical waste. And the biggest part of this property was that phone. And not only because of the messages, the photos, everything was on that phone, but that phone was the last thing that he communicated with his wife. And we couldn't give that phone back to him or to his family. And so, if you go to the next slide, the family's distress over this phone has been so monumental really for them. And explaining this to them and being open and honest, which is what we've done. But for them, it was, well, if that's how you treated his property, then how did you treat him? And as I said, from a clinical point of view, we don't have concerns about his clinical treatment, but the family now do because of what happened with that property. We've had meetings with the family, they've had the records, and it's an ongoing relationship. I know this family very, very well. I've met them several times now. We have a process when property is lost and we can go through a small loss and claim. So I've done that process and it wasn't an easy process because the emotion attached to this It's very hard to get across in a application for financial compensation. And I know we have an audit trail and auditors about how we deal with public money. But one thing I learned, if I attend that small losses and claims committee and talk through not only the physical loss, but also the psychological impact, I got the compensation that I felt was reasonable for the family. And so we've resolved that component. But positive is there'll be clinical representation at the small losses and claims going forward. One, because of that, but also so we understand the breadth of this issue. And part of the reason of bringing this to you, this is a very unique story. I can assure you that the clinical waste bag incident was never repeated because we learned immediately from that. But property of our patients can be a problem. And we've really got to work hard to try and understand how we can make that better. And as I've tried to explain, the impact of losing property, all of that great clinical care that we gave, it throws doubt on what that clinical care looks like. And we really need to work hard at how we can try to avoid this happening. Right. I think I've said all of that. Next one. Okay. So as I said, so attendance at that small losses and claims is really key. But also, what are we going to do with that information? We're losing teeth, we're losing glasses, hearing aids, and it isn't just a problem in this organisation, it's a problem in other organisations too. So it's learning as to how we can really try to make this better. And Richard couldn't take responsibility for his property at that time. So yes, we did a property form, so we know what we threw away, but that hasn't really helped in the bigger scheme of things. So we really do need to understand how we can make this better. And I have to say my relationship with the family is extremely positive now. And there will be a resolution to this. And knowing that Linda would have liked to have spoken to you, but she struggles. It's so raw for her. Maybe she would in time.
Thanks. Thank you. Thank you both. Yes, that's very powerful. I was just thinking actually of sort of little things I've got from family members. It's the sort of sentimental thing, but little items, if they've gone, you know,
Yeah.
you keep those things. I really feel for them. It's very, very sad actually. Any questions or comments?
It's only the same observation you've just made. What jumped out at me and touched me in terms of my experience was the slippers. You know, my mum kept my dad's slippers for years in the same place they always were, and they were just a pair of scratchy old slippers. But to her, they were dad personified. And I think when I've gone into hospital, I've always thought I won't leave any valuables. But what we don't do is put a value on things like that.
Yeah.
And that's incredibly powerful and very sad for them.
Thanks, Alison. Thank you, Emma. Both really powerful stories, Alison said. I'm just intrigued when we say we lose items like hearing aids and glasses and things. I mean, in my mind, it's kind of we're either throwing them away like we did that, or it's theft, right? I mean, these things don't just disappear. Do you have any indication of what the root cause is?
So sometimes it's very difficult to work out what has happened. What we do know of is the linen. Sometimes if a confused patient has taken their hearing aid out and stashed it somewhere under the pillow, and then we've scooped up, you know, we're changing the sheets and we've done that, and possibly that's where a hearing aid may go. Teeth end up in very different places. It's very interesting. And the most common thing is the property is lost of patients that haven't got the capacity to take control of their own property. So, you know, so using the boxes to put the teeth into, but then we open them, the teeth aren't there. They're wrapped up in a tissue in a bag somewhere. So, and that's why it's really important that we understand the details of each incident to try and theme how we can make it better, because they're not always the same.
Yeah, thank you. And so theft isn't a big problem for us.
If we ever did think it was theft, So a phone, for example, we might think there could be a theft component there. We would go through the process of getting security and police involved if we did think there was there.
Do we take a checklist when people come in, what they brought with them?
So yes, we do. And sometimes people bring in a huge amount. And we do try to encourage to take home, but of course in COVID times, there wasn't that potential to have the property taken home. And if the Sherritt family had been with their dad as they would have liked to have been, this would never have happened, as they'd have taken that property home. But it's our responsibility to look after it.
So it's really complicated. So I remember a case quite well of a patient, for whatever reason, was moving from Scotland to Devon and happened to fall ill on a train near Milton Keynes. They came in with a bag with £80,000. And as might be explained by his rather odd journey, it was not, his cognitive state was concerning. And in dealing with that sort of thing, all sorts of things come to the sort of side team. I guess for me, this story is really valuable in that we often think about stories in the perspective of the actual incident itself, the effect on the patient moment, and actually the impact of all the incidents and issues that happen in the hospital and the confidence of families and our community and our services going forward is something we often don't think about. We try and deal with the incident, close, move on, where we've got potentially sort of a really sort of quite a big impact on first and second and third degree contacts of patients when this happens. I think that's what brings us back on us.
Indeed, I can reflect the same thing because I think it's that powerful point, isn't it? That I certainly know from experience that I think when someone, particularly when someone's died, or even if someone has had a very bad experience and a poor outcome, let's say, in terms of what the family might have hoped for. Sorry, what the family might have hoped for. I said I think it's quite interesting how I think in an effort to find comfort or I could say blame, but I don't know if it is blame always in families, but that kind of, finding a way through what has happened to their loved one, be putting it onto something which could just be communication. It might not be a loss of things, but that often becomes a real focus, doesn't it?
Yeah.
And at first look, you can say, well, this happened and this person actually recovered. And went home, not in this case, but it could happen like that. But someone will still focus on this point. So I think it kind of the same point you're making in a way in, but I think we can't ever dismiss what seems like the significant clinical piece, and then these other things like slippers or a phone that's got photos. And I'd imagine you hear quite a lot of that in patient stories about, the treatments happened, perhaps they're happy with the outcome, but the communication.
Absolutely, it can be the smallest of things, and it's just that throwing that light then on my whole journey. And if you've not got this bit right, what else have you got?
Yes.
Yeah, I think it's very much so the emotional intelligence side, isn't it? You're thinking of unintended consequences from the whole experience. Absolutely.
Just speaking from my own experience of dealing with customers, it's quite interesting how, I know it's not in exactly the same way, but things can go terribly wrong, but you can do something to get things right. And that small things leaves them with a fantastic impression that they possibly shouldn't have. But the converse is equally true. You can do an awful lot right, one thing goes wrong, and it leaves that halo effect is huge. And it's quite interesting how those things can work in those situations in both directions.
I mean, the good thing, I think, just reflecting on this as well, is around the openness, and actually, we have to, in a sense, we have to take that what comes back from relatives, and we have to take it on board. And sometimes you need broad shoulders, but it's very important.
And it's not shying away from it; it's facing up to it. And it's been we're still on the journey, but I can't make that better, but I can do everything else to try to get us to a resolution.
Yeah, absolutely. Thank you very much. I don't.
Yeah, that's 2 years ago. Probably are dealing with lots of ongoing. How do you deal with that?
From a personal point of view, I think, if I didn't care, I perhaps would have tried to put this to bed a long time ago. But you put yourself in their shoes. and I can't imagine what that must be like. And if I could have somebody that I could be talking to, venting when I want to, crying when I want to, and feeling that I'm being heard and listened to, I think they do understand now that nobody did this deliberately. This, nobody had the intention of doing this. That they're at that point now. So for me, it's seeing those small gains in this journey that I'm seeing a family that are starting to build themselves back again. So that gives me that reward.
Thank you very much. Okay, well, thank you. That was a very powerful presentation. So thank you very much. Thanks for sharing.
Thank you.
Right, going on then with the minutes for approval. Has anybody got any comments, any omissions, errors? No. So we can take those as accepted. Thank you very much. That's noted. Right, and then going on to the action of matters arising. Right, item 4, maternity self-assessment. This is coming back in January.
So this action to me is from March 22 and it feels quite dated at this point. So firstly, we've had lots of discussions here since then around the maternity assurance group, which has since been set up in the minutes in the pack. On the specific issue of the maternity survey, we have had alongside the bargain results, so we'll come back with those in due course, and I'll come to Mag as well. But I don't quite understand what that action now is in that context.
No, I did wonder. I mean, as it's coming back anyway, through the, yes, through the Mag, and then we'll come back to the board. So I think we can say that's we can drop this one off because it's going to be picked up. Come back in different people are happy.
Will that come back in?
So we can Mag in January, we'll have the survey results and as soon as we're out.
Thank you.
Yeah, so we can bring it in there. Great, thank you very much. I think this was specifically, I just need to point because it looks from the action that it's more than just the maternity risks, isn't it? But I think this was specifically focusing on maternity risks. Is that right? Yes, okay. It's just the wording looked a bit broader. Thank you very much. The board assurance framework on item 10. I think we're coming back with that, aren't we?
So we'll have a broader discussion following the seminar in part 2, just of what's going to happen next at subcommittee level.
Yeah, great. Okay, thank you very much. Performance report.
January 23, I think. 22.
Oh, yes. Okay, that's coming back in January. Violence and aggression programme. Actually, there are 3, aren't there?
3, yeah. So
Yeah.
the status is being published, and I'll send it round to NEDS in its published form. The figures for violence and aggression I'm going to bring back to the audit committee as part of the routine health and safety report. So we'll do a look back across the last 12 months, and then I'll include it then in the upwards report to the board. And we're working on finding staff and patients who would like to share their experiences of talking through when they've witnessed or experienced violence at work or within the hospital. It's quite difficult to find people who want to speak about that. Obviously, it's quite a traumatic event, so we want to do that with the appropriate support for people.
Thank you very much. Can I just, because I was out of curiosity, I had looked online around the victims' charter, because what pops up is a code. Now, is that? Do you know if that's different to the charter?
So there's a victims. There's a victims charter that it's what support we will provide.
Yeah.
For staff staff particularly.
For our organisation. Oh, right.
There's a victims code nationally.
Yeah. Right. Okay. Got it now. Thanks very much. Any questions? Okay. Look forward to that. So we'll keep that on for the bits that are coming back.
Yes. Yeah.
Research and development annual report. Oh yes, that's mine. Just to say, I've been in touch with the ICS. I've had a conversation with Sarah Whitman, who is one of the Dr. Sarah Whitman, who's with the ICS and is the lead for, I think it's the Research and Innovation Hub that they're developing at the ICS. So I had a conversation with her, which was interesting. It's still in the early stages. And I booked in to see Professor Gert Randhawa, who's at Bedfordshire University, funnily enough, a former colleague as well. So I'm going to catch up with him to find out around it. And there's Dr. Yanis Pappas as well. I will be catching up with him because there's a whole sort of programme around addressing the inequalities in health in our system. But they're very much looking at what work is already going on, but also what we can do as a system to really help sort of learn more and look for innovation around dealing with things. So I'm hoping that once I've had this conversation, as I say, they're still in the early phases. There wasn't a huge amount I couldn't get back, but obviously I'll be talking with colleagues and hopefully we'll bring it in. Obviously we have our own research at the hospital as well. I think they'll produce some of their own. But this is a slightly, it's not necessarily purely clinical. This is very much around the research in the whole factors that contribute to inequality in health. So it sounds quite exciting. So I'm hoping that once I have a few more conversations, I'll have a better understanding and come back with colleagues to explain. Okay. Thank you very much. And the forward agenda planner, that's for January. Yes. Anything that I may not have picked up or we haven't got any action on? Great. Thank you very much. Then going on to I've got my chair's report, which obviously is attached with the papers. Just one thing I should correct is I put we're having a board development in December. I was jumping ahead. It'll be in the new year. So we have got a seminar in December, but the piece of work I was talking about exactly in the year. You lost our colleagues there. Let's take a place. Any questions at all? Updates? No. Thank you very much. Okay, I'll hand over to Ian, who will give us a chief exec's report.
Thank you. So in Joe's absence, I've been chatting to colleagues about things they feel should be highlighted. So thank you. And if there are any questions, I'll obviously ask colleagues to help out. So first and foremost, it's really, really busy on the emergency side at the moment. It's not COVID. COVID levels in the community are relatively high still, but COVID levels in the hospital are not causing us any particular issues. We're on OPAL 4, and OPAL is the operational pressures escalation level. Four's the highest. Not really meant to be there for 48 hours or so. We've been there a couple of weeks. Lots of other acutes are there as well. What that actually means for us is we've got lots of patients outlying at the wrong place. So medical patients on surgical wards, surgical patients on medical wards. We've got 30 escalation beds, i.e. beds that aren't in our funded staffing establishment open, and those include day surgery. So we've got 12 patients, night patients in day surgery at the moment, which clearly has an impact on our ability to get patients through day surgery. And at 6 o'clock this morning, we had 12 patients in the emergency department who we know we want to admit and who we're trying to find medical. So quite a pressurised floor. Knock on of that is that we obviously have increasing concerns around planned care and our ability to cover in terms of elective surgery and other elective work. You'll recall that the latest national targets, there was one around 104-week waiters and eliminating those. They haven't been a particular problem for us in Milton Keynes. The next problem is 78-week waiters. We're trying to eliminate those by the end of March. When I say eliminate, I treat those patients in the waiting list to the end of March. And we are pretty concerned about our ability to do that. The reality is that all other trusts are going to be in that same position. We've got patients obviously waiting for admission, so trauma and orthopedic patients waiting for admission who will be threatening a 78-week boundary come the end of the financial year. We've also got quite a lot of non-admitted patients, so outpatient type of patients and outpatient procedures waiting over a year. Ophthalmology is a particular area are applying lots of focus. So concerns both on the emergency and the elective side. I think in terms of our peer position, we're still doing very well, probably top decile in terms of the emergency performance, but we're slipping back a bit, and John will probably have bottom half just about, just slipped beyond that 50th centile in terms of elective care. And we have been very careful not to have patients in our emergency department for more than 12 hours, and we feel that's a very poor experience for patients. After there's been a decision to admit, we do lots to move those patients before 12 hours. And in the olden days, 12-hour breaches were things which didn't happen in the NHS, so it happened very rarely. Last month, September, there were 1,000 a day across England, so lots of patients spending lots of time in those departments. And we still have a very low tolerance level for that, so we're not keeping patients that long. And we may need to adjust our risk appetite in relation to emergency and elective care. So we'll talk more about that in the executive team. It's something on our minds. So that's the busyness element. The second element, I think, is related. So it's ongoing concerns around the cost of living and linking that with industrial action and threats from managing water. terms of our ability to do additional discretionary work and indeed our ability to maintain some of our non-emergency services. A number of ballots have happened, so GMB, which doesn't affect us but affect ambulance trusts, the RCN and the RCM have all balloted. No results back yet. And we're very excited to be part of Operation Arctic Willow, which starts on the 14th of November, which is essentially a tabletop exercise across the country in terms of how we would cope with industrialisation, but that threat clearly. Another thing to let everybody know about is a patient who unfortunately died in our hospital, and the reason I'm telling all about this is it's reported as a death in custody. So this patient was sectioned under the Mental Health Act and died with us. Therefore, death in custody. Had very complicated medical issues, which were being attended to by the relevant specialties, and the patient was on the list to transfer to a surgery centre in London. She deteriorated whilst waiting for that transfer, went to intensive care and died. There's lots of reporting appropriately we need to do to the CQC and others, which we are doing. We will look in depth at the clinical care and the delays for the transfer to the tertiary unit. At the moment, I don't have major concerns to clear that major as the investigation proceeds. That happens around. In terms of vaccination, so I think we started our Protect and Reflect event the day we last had for a board meeting here. Protecting in terms of vaccination and reflecting in terms of doing staff surveys. We, I think, currently have 38 to 39% of our staff vaccinated for both flu and COVID. The target is a flexible target, it's between 70 and 90%, and being at 39% now means we're on course in terms of our trajectory and what we wanted to achieve. I think it is important to note that it was only 6-7 months ago we were sitting here talking about the VCOD, or vaccination as a condition of deployment, which was something the government sort of marched us all up to the top of the hill on and then cut down again. And that, I think, does make all these targets around vaccination more challenging, more interesting going forward. So we'll see what the impact is here and elsewhere. I think 38% is probably pretty good compared with peers in other parts of the country. A couple of estates things. Firstly, I think we've all been around the Maple Centre when it was empty. It is no longer empty. It was open on Monday morning. Both for Ward 1, which is the medical admissions unit up on the first floor, but also for ambulatory care, both medical and surgical downstairs. And so far, so good, really. It's a great environment. Patients have valued and appreciated that. I think staff likewise. Inevitably, in a new environment, there's just get used to the new place and make sure that our services adapt accordingly. But there's been no adverse noise or concern, and lots of positivity about that new building. So that's great to see. And we also spoke last time about radiotherapy and our commitment to building a radiotherapy facility here in Bunbury. The hope is that we'll be in a position to sign that contract later on today or tomorrow, and a meeting later on this afternoon to go through the details of that. Two final highlights. One, we had a visit from Maidstone colleagues, so colleagues from the NHS at Maidstone about 2 weeks ago. They came to understand our digital journey and also what we've been doing around staff wellbeing. Slightly unfortunate in that lots of the IT team were in Kansas at the time. Lots of other people had COVID, so it was pretty amazing actually. Not including myself. They went away amazingly impressed actually by the things we've been doing on both fronts, and it's really good to get peer review from people who understand the issues and challenges and are dealing with the same issues in their trusts day in day out. So that's great. And finally, the HSJ, the Health Service Journal, runs annual patient safety awards. And we received a highly commended, so we didn't win, but we were highly commended. Not all categories had highly commended, so clearly judges were impressed. This was in the patient safety pilot project of the year, and that reflects the safe work, which is a different way of investigating incidents, which is that's important. And in essence, the first year of our patient safety specialists work they've been doing, so that's really great to see. I think those are things I wanted to mention. I'm not sure if anybody that Greg's first wants to raise anything else I missed.
Just to see if there's anything else. Was it an additional
It
case?
was,
Yeah.
just to say that we also recognised Black History Month in the Trust during October. There were lots of events, lots of really great work by our network as well, the Black Asian Minority Staff Network, who led some, I think, really powerful company decisions, raising awareness, challenging the executive team, particularly around inclusion and around further work that we must do. Also, just mention two things. One was the Kirkpatrick report that was into Kent, into the maternity issues at Kent, which I will bring back through MAG and through to the board once we've done some work against that report. And Milton Keynes Council, a completely different subject, have published a cost of living winter plan for the local authority area, which is really well worth reading. I'll try and send it around to people. It's on support for residents around cost of living over the winter, particularly. It's a really great piece of work they've done around supporting local people. So,
Great, thanks, okay. Thank you. Gary.
It's just with respect to the pressures in the emergency ward, I just wondered what's your sense of how quickly the medical centre will help to alleviate that?
So I think not very quickly is the honest answer. So firstly, the old Ward 1, which we have vacated, isn't mothballed, it is being used to allow us to move one of our other wards into that area so we can do some estates work there. So we don't have any additional bed capacity as a result of opening the medical centre. We will have some beds coming back on stream a few months down the line. I'm a bit vague about that because we've got some choices to make about how quickly we bring them back on, so that would be good. In terms of the ambulatory function downstairs in the medical centre, we've invested, as we've discussed previously, in a team to enhance slightly what we're offering now. But we're really conscious in order to make the best of that building and the best we can possibly do in terms of ambulatory care. There's going to be quite a lot more investment in staff required. It's quite a large price tag, so that's a work in progress. It's being worked on. So whilst it's a beautiful building, it's not a bad suit.
Thank you very much. Any other? Hayden and then Bev.
Thank you. Do you see us staying at Oakwood level 4 for the foreseeable future?
I suspect we'll be between Oakwood 4 and Oakwood 3 for the next few months, probably. They'll be
Like the way through the winter.
Yeah, no, clearly if everybody's Oakwood 4 all the time, then it becomes somewhat an optimal measure, and there'll be some pressure to make sure that those who are really struggling are at Oakwood 4. I don't see any days of Oakwood 1 and 2 coming anytime soon.
No, I mean, I was just thinking, I was on the call with the system partners yesterday, and it's the first question they asked me is when are we going to de-escalate and what does the system need to do to help you? And to be honest, the challenges at the moment around what we've talked through here before, discharges, the hospital avoidance pathways are all constrained in terms of staffing challenges elsewhere. So whilst it does feel as if it's almost becoming a status quo, I think we have to continue to reflect that level of and I think it will be particularly difficult even with ESDEC. It will help us decompress ED to some dysfunction, but I think it's going to be hard to know that.
Clearly nationally with 1,000 patients a day waiting more than 12 hours in PD after the decision to admit. From that, you'd assume most organisations go over 4. Clearly the thresholds may have changed. Several years ago, we would always have said that the 12-hour wait is going to be another one if it was due to pressure.
Thank you.
Just linked to that, I'll just go back to 78-week. And so is the 78 week, is that a national target or is that a local ambition?
I think it's probably a national ambition.
And presumably, yeah, if we say it's over 4, there's no way that's going to happen. What would have to happen for that to be achievable?
Lots John to answer that.
So the answer is, and Emma can correct me, but I suspect nationally we'll get quite close to the end of March target for 78 weeks. And then very shortly afterwards, we'll all get much worse. Because the target is at a particular point in time to get 78 weeks. Not the day after, the day after that. And there is a bow wave looking at the number of 52-week waiters.
Yeah.
It's going up and up and up. And then I'll get to progress. So if you like, it's a target for the end of the year, but I don't think it'll be achieved for very long.
Any other questions at all? No? Thank you very much. Thanks for that, Ian. That's great. Going on then to item 8, the maternity insurance group. Are we anything?
So I'm afraid you're stuck with me on this one too. So there are minutes of the maternity assurance group. These are the final minutes, but you may recall you've seen these draft minutes before, so they're not really helpful. We have had a further meeting of the maternity assurance group since, and there's lots of work going on. What I actually want to do briefly was mention Kate, which is this, the Kirk report into East Kent, which came out about 2 weeks ago. reading through it, and it looks at the care of women and families in Kent over a period of about 10 years or so. It is really very depressing reading. It has lots of mid-stats report about it in terms of looking at things and recognising that some of these issues, to a greater or lesser extent, probably play in lots of organisations. What Kirkup's done, and he's a former Deputy Chief Medical Officer and knows this territory very well, has essentially, rather than coming up with hundreds of very specific recommendations, he's come up with 4 themes of recommendations and nothing more, which is really helpful. And he's really pushed quite hard, and actually, in each of your organisations, you need to focus on these four fairly broad areas, recognising this isn't just with East Kent, it's a problem that, as he now knows, Morecambe Bay, East Kent, Nottingham, Shropshire, etc. And those just at a really high level, I think. So I took this on my holiday last week as holiday reading, and it's an interesting read. I will share it, and I would recommend people read the first 5 or 6 pages, which is it's quite a good summary. But essentially 4 key areas that he wants us all to work on. First one is national work to improve the way in which we monitor the quality of maternity care. So his feeling is that there are much more sophisticated ways to be able to identify a service which is getting into difficulty at an earlier date than we currently do. Secondly, a real emphasis on non-technical skills, and actually an awful lot of this is around communication and non-technical skills rather than technical. Thirdly, and obviously closely linked, teamwork, and clearly very siloed behaviour across the 2 hospitals he looked at in East Kent between different specialties. And fourthly, interestingly, we had a bit of discussion about this last time we met, organisational behaviour. So East Kent was clearly both looking good and saying it was good whilst it was actually doing a job in a number of areas. And for those long memories, when Dr. Foster, the company, was sort of a big public thing, East Kent was named as the Trust of the Year, at least once, maybe twice. And they had this sort of slightly magic for a few years. They actually took a while to sort of get through that and actually address and recognise some of their problems. Joe referenced last time, the CQC reported to SCAS, the ambulance service, which Kate mentioned as well, which is very critical of sort of extreme positivity that didn't recognize the reality. There's more about it here. So we'll take that through MAG, obviously. I will circulate the report. I think it is interesting for those of you who have any time with that.
Very much. Thank you.
Any question?
Only that that and the thing that Kate mentioned. I mean, is there any way that can rather than be circulated? I'll keep saying about this, use iPad so that we can refer back to it.
Yes, yeah, have it stored on iPad. Yeah, no, that'd be really helpful. Ivy.
Sorry, a question for Ian. But I think you just reflected it in the 4 themes point. One of the things, I guess the notes were really. I wonder in the sea of everything that we're looking at in maternity, which we have talked about in previous meetings. How do you think that we're standing back and reflecting on what are the 1 or 2 things we're really dealing with here that are the key things that we Milton Keynes University Hospital need to be looking at for our patients?
So I'm going to stay with maternity to start with. Come out of that in a minute. But of
It
those,
is maternity, I was meaning, sorry, yes.
so of those 4 areas, the sort of monitoring and the data, we're up for that. We value data when it seems robust. It is a national ask to whether that's that sophisticated system. Clearly, we have had several conversations around sort of how we balance the positivity and encouraging staff, etc., versus the lived experience of some of our staff and patients in what's been a really difficult few years. And the fact that we're discussing that is in itself, I think, good. Some places clearly aren't or haven't been. And then, in terms of sort of the non-technical skills and the teamwork, we cannot and must not be complacent, but those are some of the areas we've been working really hard with our obstetric midwifery teams on for years now. And we've discussed at the board in the past the challenges we had in relation to postgraduate training in O&G some years ago. I think we've been open and relatively successful, again, not complacent, addressing that. And Joe and I have talked about some of the engagement sessions we had with earlier on the quality of care, etc., which again I think demonstrates we do understand lived experience rather than cut ourselves off from it, which I think is the criticism we see.
Thank you, Kate.
There's one of the recommendations made in the report that I'm really interested in, and we're doing some work around this, and it sort of links to the same pilot, but more broadly than that, which is around how we communicate with families and how we engage with families and how we are demonstrably open and honest. So we're looking at, so the same pilot does that really brilliantly, engages people in the process of serious incidents. So obviously we're looking at now how we can expand that outwards. We're also doing some work with Harmed Patients Alliance, asthma, and lots of other groups of patients with lived experience of bereavement and being bereaved through healthcare harm around our complaints process, around how we engage people in everything from instant investigations through to complaint letters, through to public statements following inquests or media statements more generally. So we're doing a lot of work around that, and we're one of a very small number of trusts to be doing those work that we're leading. So I think I'll bring that back at a stage where it's more sort of ready to be brought back, but it's really interesting work.
Just one quick follow-up. Obviously, look at that when it arrives, but are there any key messages for non-exec directors in that?
So yes, there were, yes, we need to go back and call that specifically, but I'm just giving lots of messages there for boards, unitary boards, rather than just.
Probably picking up on that, Bev, is I've had discussions now with the Maternity Voices Partnership. I've started sitting in on their meetings. There's some really interesting stuff coming through from there. Obviously, very interesting from a non-executive perspective, but also Wendy Matthews, who's the chief midwife for the region. I've had a discussion with her, and there is this non-exec forum that's been set up. And I found out it's an informal thing. It's nothing, you know, it's not there for assurance and stuff, but actually it sounds like it's probably quite a good forum to just hear what's happening elsewhere from a non-executive point of view and how people are getting assurance. So I think there might be some good tips coming through from that, and obviously we can share what we're doing as well from our perspective. So I think certainly I've had a quick look at that, but and as I say, with these discussions, I think the big thing is around, you know, listening. It's around outside, obviously the reports we're getting. It's pretty much doing the sort of, you know, the normal non-executive work, which is around meeting people, listening, meeting staff, meeting patients, or service users, I should say, on maternity, because more appropriate terminology for them. But yeah, I mean, if there's anything else, obviously I will raise it with colleagues. Any other questions? Thank you very much. Thanks for that update, Ian. Are we going on then for this serious incidents and learning?
So I'll take this one on the basis Kate's then got a long string of papers. These two papers are in the wrong order. So page 33 is the report, page 25, which is the Register of Future Deaths correspondence, is appendix to the report. So the report first on page 33, I'll take it as read. It's about our serious incidents processes, but probably 4 things to highlight. Some of them I think are known to all members already. The first one is clearly quite a lot of discussion in the paper around pressure ulcers and deep tissue injury. The patient safety specialists have done a good focused piece of work with the Ward 1 team to try and understand some of the key issues from a slightly different perspective, through a different lens to the traditional root cause analysis report, and that's what we did in the paper. Secondly, clearly a focus in here both on deep tissue injury and also that medication incidents on Ward 23. And they will say a little bit more about that, but it's an area of focus. So Ward 23 and Ward 25 is both had some challenges. Thirdly, a significant incident reported in here around the maternal death. Really, whenever there is a maternal death, everybody is hugely concerned about that because of the devastating consequences for the family. There are a number of different causes of maternal death which are well known in the National Confidential Inquiries. Some of those causes are evidently preventable. Maternal death in any service looks very hard very quickly. In this particular case, the concerned died in the community about 5 days after a birth. It seems, well, it is the case that she died from post-puerperal sepsis, i.e. sepsis after delivery. Looking back at the notes insofar as we have, there are not any major or clear areas of omission or commission in relation to this case. That's all said, it's been referred to the Health and Safety Investigation Branch HSIP for pre-investigation, so we're hearing more in due course. But in terms of things that we really worry about enormously when there are a major incident such as this pulmonary embolus, for example, that wasn't the case here, which I think is is a positive in terms of our processes and systems. Less devastating outcomes, but I'm saying more in due course. The final thing then was the PFD response, which is therefore I think a fairly robust but also pragmatic response to the issues the coroner raised around alarms being silenced. This is an area where there's a substantial interest come to a sensible point, which is where we're going to change the limits on the alarms, so they will still alarm, or change the thresholds that are less false negative, so to speak. Hasn't come back to us, which usually means it's satisfied.
So just on the second part of that PFD, which was around perennial disclosure. So obviously we disclose records to the coroner to enable him to fulfil his function. And there was some concerns raised around one particular inquest, in fact, a very recent inquest around disclosure of records, because eCare is not, our eCare record is not made to be printed and disclosed in the way that a traditional medical record would be photocopied and sent across. So we've had various different meetings with the coroner, with our lead, the clinical lead for eCare, to work through how we can support him and his officers to get the right access to records and make sure that we are disclosing appropriately our records without sort of giving him a 4,000-page load of notes without any order to them. So we resolved that, I think, to his satisfaction. We'll keep monitoring it to make sure that that's the case.
Thank you very much. Any questions?
Yeah, Ian, I noticed, maybe I've just missed it, but there is a focus on Ward 23 and 25, and I just wondered, I think it was 128 cases, I'm trying to remember that instance. How many from those two wards?
I just wondered. So the tables on 44 and 45 will give you a sense of that. I think the important thing to say is there's always a bit of a case mix issue as well in relation to where SRs might occur. So Ward 23 firstly is very big. So 40 plus beds rather than 26, 27 that we have on most of our other wards. So we'd expect perhaps to see more issues. And secondly, the case mix there is non-elective surgery, including patients with fractured neck and feet. So in any hospital, wherever you see that patient group, you may find more issues because the care is more complex. That said, there is still more instance on the 23. We'd like to see. Great.
Want me to give an update on the QI programme? So we have quite a detailed QI programme for Ward 23. So in particular around deep tissue injuries, the TDN service is up there. It's dedicated on that ward, providing direct hands-on training with the clinical staff as we're identifying issues while we're there. We've put in the MedStrong have a presence on there on a daily basis as well about the management of the beds. So they've actually done really well on the cleanliness of the environment, the getting rid of the clutter. That's all happened. There's a very, very strong clinical leadership, including myself. I spent a couple of hours up on the ward every day. We're in constant conversation, in particular with the band sixes. So these are the individuals who coordinate care on a daily basis and strengthen that group to hold their that whole clinical team accountable. It's quite a difficult environment. It's a difficult environment from the perspective it's quite spread out. So putting the right expertise on there. We've actually brought more experienced band sixes into that team in terms of its clinical leadership and teamwork. Part of that, so all of the quality improvement work around pressure ulcers is part of the Trust-wide programme. So I don't expect to see this to just drop off really, really quickly. The amount of, we've got to keep on top of everything. We're looking at the data at the moment. We've completed a big cleansing exercise, and we're now actually being able to communicate both to the ward themselves but Trust-wide about the levels of pressure damage and where we need to focus our activities. There is a big leadership and cultural programme with the band sevens about maintaining oversight in the clinical record. That's really interesting because we can look at the completion of the risk assessment. What's probably most interesting about Ward 23 at the moment, their compliance around the completion of the risk assessments for like Waterloo, which is around pressure damage and falls, is quite high. Where they need more improvements is around the nutritional component, and as Ian has just highlighted, having patients who are on a fractured nerve pathway, they tend to be older, more vulnerable, more frail, that focus on nutrition. So it's a whole suite of activities. It's not just about it's about essential care in its broadest sense. It's not just about the pressure damage in and of itself. But that will go trustwide. I'm more than happy to bring that back in to the board when we've got it all finalised, which it's moment.
So I think just on Ward 23, so some early flags around some care quality issues, really rapid program, it's iterative, and it's sort of making diagnoses while supporting simultaneously, which Yvonne's just outlined. Back through quality control.
And given the lead up to this, you talked about the pressures on the hospital. That was really welcome, all the actions that have been taken. And there is this presumably pressure wave coming at the back. Should we expect to see more serious incidents?
So I think we have seen more serious incidents over the course of the year. We would always have known, we have always known that Ward 23 is challenging for us. Not because of its size, there are lots of 40-bed units across the country, but the layout of Ward 23 is probably not as smooth as we are today. The case mix.
Is that the ward with the strange central console?
Correct. Yeah, correct. And then the treatment, so the patient groups there as well with COVID is become entirely non-elective, so emergency patients. Therefore, quite a few different surgical specialties in the same area, because we in the pandemic we were separating streams. And I think with fractured neck and femur patients, particularly with the downstream challenges around care provision, etc., it is a place that is vulnerable to these sorts of challenges that need to be recognised early and to be dealt with.
Thank you. Ian, thank you for the report. Just interested in your view of both pressure ulcers and medication errors. I think these are the top two that keep coming up repeatedly since I've been here at least. And we're always, I think, fairly assured by the amount of action taken when they do come up and the things we put in place, but they still come up again. So I'm just wondering about your confidence, and maybe it's a question to both of you, that these actions that we've just talked about are really going to have that impact. Yeah. And I guess the secondary question to that are we furnishing our staff with all the tools possible that could help, especially things like pressure ulcers, but in truth, medication errors as well.
So I can say this now, I couldn't have said this 6 months ago, because nationally we've moved to this new piece of patient safety incident response framework, this entirely new framework for dealing with incidents. I think the old system of root cause analysis was not fit for purpose in relation to some of the higher volume incidents, such as tissue damage, such as medication incidents. Because every time there was an incident, it just generated in industry a 30-page report, but it was all very bureaucratic and distant. What the patient safety specialists have done, awarded at the HSJ conference with the SAFE pilot, is they brought staff and patients into those discussions and incidents right at the beginning. So we have very, very different insights and understandings of what's causing. We want to do, rather than pressure ulcers, rather than having 20 or 30-page reports each year with all these slightly diverse action plans, essentially having a trust-wide action plan for tissue damage and medication incidents, and probably falls the three big incident groups, and really you have that central trust-wide action plan that everyone's brought into, education programs feed off, sort of a living document. So if they're going to govern in a school, for example, have a school improvement plan, a living document, to have one of those for these three high volume areas. Whenever an incident happens, yes, do some work to understand it, of course engage the patient, but actually if the sort of the root cause and things are part and parcel of the overarching improvement plan that's dealt with through that, then leave it there and put your discretionary effort into the improvement actions. So it's all about moving from the investigation, the diagnosis, into actually the improvement. I think the same is probably true of all those areas. Medication, so has been some interesting feedback from commissioners. They think perhaps we're over-reporting the pressure damage. That's interesting in terms of peers. I.e., we will report something else as a serious instance, other places might not. So we need to review that a little bit, but at one level that's somewhat bureaucratic, also given the patient are. On the medication incident side of things, one of the reasons I think we have a higher level is because they're trying to prescribe. Therefore, incidents that have happened since time began are now much more visible and evident and noticed than they would have been previously. So I think vacation incidents should be higher. Clearly, the proportion of those which are serious. And we talked previously about pharmacy staffing, which has been a challenge, is improving. So some green shoots.
I really like that approach, sort of improvement plan for the themed area. That makes a huge amount of sense. On the pressure episode, how do we link with community in terms of community facilities and so people who come in with maybe low level tissue damage that then escalates here, but if you did have started further back, improvements that have started further back, how can we lock community services back into our improvement plan?
So we do have a mechanism, and actually very helpfully, our chief clinical information officer has done a lot of work with us recently. So we've got a new wound care chart that we're about to launch. It's literally just come out of pilot and had approval. So we have a mechanism for recording people who enter our hospital with pressure damage and recording that quite accurately, and then feeding that back out is really critical to that. But it is back to what Ian has already highlighted. We do over-report our pressure damage, and I'm not confident about, which is why this is quite an extensive quality improvement programme, is when we come to categorising our levels of pressure damage. I think, but I don't have the evidence yet, that's why we've done a big data cleansing exercise, is that we report what our moisture lesions as category 2s, and so that whole cleansing exercise, being absolutely precise about what is our number of category 2s, what are they 3s, what are they 4. So that's a huge piece of work, and that's why I have the TVNs with the Tissue Viability Service actually working with the team on 23 to make sure that they're validated properly, that we're reporting the numbers properly, and so that the improvement actions that we put around them are actually based on a real problem, and not on problems that are confused by data that isn't particularly accurate. And then what falls out of that is, so the other question you'd asked is about, so I'd typically expect the board to be talking about pressure ulcers, falls and medication errors. They're normal. It is the QI programme that Ian has kind of highlighted is giving dedicated actions to individual ward teams to purposefully reduce these numbers. And that's a bit different to what they've had before. So we now have a numerical framework that's saying, okay, in 6 months' time, we have to see a reduction of 50%. And as we monitor that week on week, and actually they're monitored weekly and monthly, what are the interventions that we need that are both trust-wide, and what are the bespoke interventions that we need to put into individual ward areas to help them solve some of these problems. And that's an exciting piece to it. The clinical teams have been very engaged in it. In terms of the tools that we provide, the Waterloo is a risk assessment that is known to work. I think actually when we start to figure out and solve this problem, we may look at a different instrument. At this point, it wouldn't be the right time to look at changing that instrument. For the clinical teams have been using it for quite a long time. But actually, we are looking in considerable detail at the accuracy. So if you're doing a risk assessment, that risk assessment has to reflect the actual patient's risk. And that's, again, why we're on the ward saying, you know, we've got a risk assessment that says that this person is at moderate risk with all of the subsequent care interventions that you'd expect, but they look more like they're high risk. So let's have a conversation about this. Let's talk through it. So we're looking at all of those things, and then we're looking at that role of the ward leader, that having the oversight of, are people assessed? Are the assessments done in a timely way? Do we have interventions in place that quickly? The beds are a key component for us. And you'll have seen on that SI report that it is absolutely critical that the pump is in use. While they're in use, and Bev, you and I have had that same visit, same conversation. Yes, we've been there having those conversations. We have this really useful tool, and some of this problem is about our lack of attention to detail, in my view, in some cases. So that's why we're taking it very, very comprehensive, right away from reporting to board down to the actual delivery of care in the ward areas. We will do a huge amount of work with our healthcare assistants. They've been neglected in terms of their tissue viability training, and I'm really, really keen, which is why we're working very closely with 23 to make sure that they're getting that care with the patient, so that we're learning in the clinical environment. They've had, so interestingly, what they said, they've had the study days, and that's very overwhelming for them, and particularly if you're new to care. So if you're talking about somebody who's on a fractured nerve pathway, that needs to be reinforced in the clinical environment. So just on that narrative alone, you can hear that's not going to resolve, we're not going to resolve these problems very quickly. They're part of education training, they're part of the cultures and the ward environments. But I'm confident that we will start to see this decline, and we'll see it in a stepwise fashion.
Thank you very much. Thanks.
Sorry.
Last one. Okay.
Sorry. Thank you for highlighting all the actions that you're taking, and I think obviously that will bear fruit in the core. What I was quite interested to know is obviously you've already highlighted that you're working with the HCAs. Are the other MDT members being involved in that as well? When a physio or an OD?
So that's a great question, and that's the later part of this QI work. In fact, we've only started that engagement exercise this week, and on 2023 in particular. When we met with the Band 6s, we were saying, help us help you to solve this problem, and one of their key asks was more engagement of the therapy staff in the improvement program. So it's the later part, but it has just started, so we'll be able to expand on that more fully. But it is, it's absolutely critical.
Thank you very much. Thank you. A really important discussion, actually, and it's great to hear about the amount of work that's going on. That's really encouraging. And obviously, this will come back to the board. You know, we can keep an eye on it, and I'm sure there will be positive, progression. So we're looking forward to hearing that. So thank you all very much. Excellent. Item 11, complaints and patient PALS annual report.
I've got 3 complaints and patient experience related reports. The first is the annual complaints report, which is obviously a little bit old now because it's the last financial year. We talked about it with our quality and clinical risk committee. So I'm happy to take the report as read. You'll see the numbers have gone up, and they've gone up every quarter of that year. The comparable year is sort of difficult because it was a year, a sort of pandemic year, I guess. First year of the pandemic, so it's a little bit difficult to compare like for like. There's a couple of things I just wanted to pull out. So one is the number of cases referred to the PHSO, so that is the ombudsman. So where a complaint can't be resolved to the satisfaction of the complainant, then they have the ability to refer to the PHSO. And in unusual occasions, we have the ability to self-refer. I've only done that once and not recently. You'll see that we would like to get that number down obviously to 0. Really, we don't want our complainants having to go to the PHSO. We want to operate so that we resolve complaints quickly and to a satisfactory resolution for everybody. If we just scroll down, you can see the report shows areas where you can where we get the most complaints, and they're probably unsurprising. So ED, for example, is up. It attracts the most complaints because it has a huge touch point footprint for people. One concern for me is around complaint response time. So there's a graph on page 8 of that paper that shows complaints responded to on time per division. And we're not where we really need to be. So we want to be improving across this year around timeliness of response. There's also some data on the type of complaints on page 9. So the top 5 complaints issues, and you can see all of them bar one around communication. So although we've got communication, kind of separated out into 4 different particular strands, it's all communication apart from appointments. So one thing we want to do this year, one is obviously focus on communication, and Sharon, who met earlier, who was with Emma, has done some really interesting work around looking at a sort of standard operating procedure around communication on wards. So we'll perhaps look at how we can trial that. But also around getting a appointments helpline in for patients. So we want to be able to resolve those really quickly. And I think what often happens is patients call up with an appointment question and they bounce around the organisation a bit, which is frustrating. So we're looking at how we can work more closely with the call centre, central booking office around providing a helpline for patients in that. There's some interesting things in here about lessons learned. Some of them are pandemic related, some of them are around particular pathways for patient groups, which we've been working on through this year. And I'm happy to see any questions on this
report. Thank you very much. Thank you. Peter.
Thank you, and thanks for the report. Just a couple of questions, so just bear with me. But, why doesn't this report kind of get board visibility a bit earlier? It's like last year.
Yeah, to be honest, I'm not sure actually. It's been, I don't know. So I've recently taken over this service into my portfolio. So I think you're right. Some of our annual reports do seem to lag. It might be that it goes sort of slowly through the committee cycle, and so it takes kind of a quarter to get up to board. So I'll have a look at how we can get it.
Nice and good.
Yeah.
You touched on communication. I saw that as well. Massive theme, one of our values. When I was with PALS doing a visit, one of the things they said, I remember them saying that delayed feedback to patients was internal communication. So, reaching out to Ward X and trying to find what happened and whatever the problem was. And it made me think again of tools that help internal communication, so secure tools. I'm not sure that we have anything around that, but I could be wrong. Like so a secure messaging app. Do we have a secure messaging?
So are we talking about a WhatsApp type?
Yeah.
So we use extensively WhatsApp internally.
Okay.
We also use, some people use Signal and others, but the reality is that most of them are internal comms between teams done on WhatsApp. Better off for us.
And we're happy with that in terms of.
Well, we may not be entirely happy with that, but pragmatically, it's what everybody uses and will have on their phone and will respond to at home. So it's de facto, I think, what most people in the NHS use in reality.
I think you're
People say use Teams a lot, but at home, if you're trying to find a member of staff or find out where the keys are, WhatsApp is responding.
But not for patient available information.
No.
I just wondered if there was a way to bolster our internal communication and that might have knock-on effects with external communication. Because it does seem to be a big theme.
I think some of the internal communication is around just the number of transactions that people make in resolving an issue. So, for example, a PALS officer going up to a ward to sit with the patient, talk to the patient, then talk to the ward staff, and then coming back down to communicate with the patient is just not the right. It's just not the way it should happen. So we're doing some work between the sort of the PALS office along with Sharon, who's the patient experience matron, and the ward staff to say, actually, how can we just knock some of those different layers of interactions out? Because actually, most of these issues can be resolved by someone going and sitting with the patient, of course, delivering the care to that patient, and who can talk to them about their care and their relative as well. It shouldn't need a sort of an administrative process to wrapped around that. It's just unnecessary. So I think that's one of them. Some of them are around thematic issues around patients understanding different things around their discharge plan, perhaps, or the medications they've been discharged with, or what happens next. There's some thematic work that we can also draw out and do some particular QI work around improving. But I think we probably complicated lots of our processes unnecessarily too. We need to simplify them and strip them back.
Thank you. Ben?
Yeah. Really points. One, I've always got mixed feelings about complaints going up, because on the one hand, you think that might be a great thing because people are being more open and honest. But linked to that, have we done any analysis on, given the year that it was, that any of this has been impacted by COVID? I was thinking about, the lack of communication, the patient story this morning. Even if we hadn't lost everything, there might have been some complaints out of that just because of the lack of accessibility to your family.
So I think we probably haven't done enough looking back. It was one of the things that I was thinking about when everyone was presenting out. We haven't done enough looking back on COVID and drawing the lessons and looking at the impacts and what we can take forward from there. So undoubtedly there will be an impact in here, but we haven't done a look back exercise to understand what that is. PALS and Place did some really fantastic work through the pandemic to support patient contact. They did letters to loved ones. They did lots of work around property and getting things to and from people. So they were very agile in how that they operated. I think what we're seeing now is is obviously the communication, but also things like the backlog from COVID and about appointments and the posters sort of changing and rearranging, which is coming through. But there's certainly some, if we have the capacity to do it, we should certainly do some more of that.
I've heard much about the process, so I'm never quite clear when things come to board. Some have a cover sheet, some don't have a cover sheet. This hasn't got a cover sheet.
Yeah.
And so, because what I immediately wanted to know is where else had this been? Is that why it took so long? So if you did have a cover sheet, we'd have seen the report history of where it's been, and perhaps, you know, crisply what the next steps are.
I have no going through this cover sheets I've put because I'm going to pick up with colleagues just.
I mean, it seems like extra work, but it just answers some questions that we won't need to ask at board.
Yeah, definitely. I'll pick up on that.
Okay, my question is linked to Bev's, which is, have you got a sense of whether the 25% increase in complaints is because we're better at reporting them, because of the circumstances we've been in over the last sort of 2 years, or the key point here is, are we actually deteriorating our performance in terms of how we deal with complaints?
I think the complaints service has been under an awful lot of pressure. I think I'm taking some work forward at the moment, looking at staffing model for complaints and PALS, and what we need in terms of the workforce to support good patient experience. Complaints and PALS is a statutory function, and you know, we need to provide a really good service. I think so. I'm looking at that at the moment. I'm not sure. I'm not sure I can answer the question actually, other than that. So I think we can always say, well, it's good with complaints gone out because we're better at encouraging people to make complaints. I would like to seek to understand a little bit in a little bit more depth around if that's true, or if that's actually that we're seeing a real increase because people are genuinely very unhappy with the service, and I don't know the answer to that at the moment.
And I think the staffing point will help. So it's a good.
I think as well as we watch the themes that come through, I think that will help to indicate whether it's a trend in people's actual experiences, you know, or whether it is that we're just encouraging more of that comment. So yeah, we'll have to keep closer. Thank you. I'm going to move on to the next item. Next two. Yes.
So the quarterly report is obviously the first quarter of this year, so similar in terms of theme. Similar completely, so almost really a replica of what was shown for the last year in full. There's a few more examples around improvements following complaints. It does feel to me that there's some real focus that we need to have on the formal complaints and PALS element of the service. So I think when we look at the patient experience report, there's some great work reflected in that around some really innovative work that's going on. But for me, you know, working with Yvonne as well, I really want to focus on the statutory service and what we're doing, how we're doing it, why we're doing it, and really understand the kind of core business, I suppose, in terms of why people are complaining and what we're really doing about those big thematic issues. So I'll look to bring in the next quarterly report, look to do more of a focus on that, and then the actions around those big thematic issues around communication and appointments. Too, because I think for me at the moment it feels a little bit, some of the work we're doing feels a little bit dissociated from those bigger issues.
Great. Any questions? Good.
Sorry, do we have data? It might be overlooked, but do we have any data on the channels of how the complaints are being made and the timing? Is it immediately in the ward itself, or is it a bit later on?
We do have that data. It's not in the report, but we do have it. Yeah. Very happy to share it. Yeah.
Yes, thank you.
Any other questions? No? Thank you very much. Okay, so next one.
So next one is patient experience. So as you might be aware, so we've got the sort of two teams. We've got complaints and PALS who provide that statutory function, and then we've got a patient experience team, which is a sort of team that's Yvonne and I just working through around sort of structure. So we've got Sharon who's the sort of matron lead. We've got a number of volunteers doing different work around direct care, and we've got a couple of other posts that are doing work around patient experience. So this is the sort of lovely bit of we've got lots of really great meaningful work with patients and relatives and families across the organisation. So this report describes some of that work. So how the teams have been using appreciative inquiry, the patient experience platform, which we're just seeking to renew. So we purchased that last year. I think we're looking to renew that contract and look at how we really use that data that comes through. It's a really rich source of data. We're not using it I think probably to drive some of the work that we could do in the way that it has the potential to. Some work around volunteers, so how we use volunteers and where they're placed. There's been quite a lot of work around armed forces. We've got an armed forces officer who's joined us to look at particularly that pathway around how veterans access healthcare. Quite a bit of work around learning disability and autism as well. And Sharon, who Penny met earlier, has done some specific work around that and around pathways through ED particularly. There's quite a bit of work that's summarised in here. It is really meaningful work, and I think there's something for me about how we link this report up with patient experience stories at the start of board, so that we really get the sort of sense of the breadth and depth of the things that are going on in the organisation.
Questions? Thank you very much. John?
Do we have any information about volume of armed forces using?
Yeah, we've got lots of data.
Do we also know if we meet the obligations in terms of giving priority to them?
Yes, so we do lots of work with various different third sector organisations and the council around how the covenant operates in practice, and how individual veterans are advocated for and how they access. So we have got lots of data that supports the covenant. Obviously, we're going through our gold standard for the covenant. We're at silver at the moment. So I don't have any concerns about that currently. If people are interested, I can bring back data on it.
Interesting, maybe, yeah, perhaps to yes, appropriate reports, just to have the figures, just so that we get some indication. That would be good. I mean, I think the award of the silver was a real positive, because obviously, they are looking very much at the experience for veterans, and so that's a good recognition, external recognition of what we're doing. But
the other thing, sorry, that was picked up in this report is all of the patient survey work, statutory patient surveys, on which lots of our sort of responsiveness metrics will be measured by the CQC. So there's lots of surveys that are commissioned by the CQC, maternity and emergency department, inpatient survey, for example. There's a couple of others as well, so PEDS and cancer that are less regular. I'm going to have to think about how we bring these back in a different way. Again, the lag time is really long, because they put in an awfully long. They take a long time to come back the results, and then they put a embargo on for quite a while as well. Each time we're just responding to one, then it's the next. Think about how we...
Thank you very much. Okay, last point, Hayden.
Sorry, yeah, it would be great. Interesting to note the top 5 best performing units in critical care, neonatal, endoscopy, etc. That when it says the top 5 services with the most comments, does that mean worst performing, or does that mean most comments?
I think it means most comments. I don't think it's carefully worded to mean something else.
So, I mean, what are we to take away from most comments? These are the ones. What's the take?
I suppose it attracts most feedback, which you would expect actually around those patient, potentially around those patient groups. So endoscopy is an interesting one. I'll check that back. I think I'm not entirely sure, so I'll double check.
No, and really the question was, are we taking the learnings from the top 5 and spreading them throughout?
Yeah, that's an interesting point. So I think that's so possibly not. I think that interdepartmental learning is probably something that we don't do enough of. In fact, one of the patient stories I'd quite like to bring back to the board is around neonatology and around some of the work they've done as a result of this feedback, linking in appreciative inquiry in a programme of work that's really quite impressive, and actually could exactly be replicated in other areas.
That's really good, and that pulling together. I mean, I think that'd be really great to see at the board, pulling in, that sort of whole holistic. I mean, you mentioned holistic stuff earlier on, Yvonne, but if we see more of that at the board, it'd be really helpful. We can see how all these initiatives are really benefiting, what we're doing and improving things. But I guess, I mean, I suppose in terms of comments, I mean, my thought is that you want comments coming in, so I suppose I saw that as a plus, for that being maybe my bias, because I'm cut half full. Okay. Thank you very much. I'm conscious that I'm pushing time at the moment, but I think I'll suggest we'll take the next item, and then maybe I'll just bring the break forward, just so that everybody has a time of 10 minutes. So I'm handing over to
Yes, it is. Thank you, Alison. So item number 14, I think it's listed 15 in the attachment on your iLabs. Going through, so I don't know the page number. Essentially, a national letter that's come down to Ian and myself on getting it right the first time. It's been a national programme that's been in existence for a number of years, actually, and it's been very much prior to now, very specialty specific, and we've had inspections and action plans and improvement processes following on the back of that. Professor Tim Briggs, clearly part of the national team discussion at the moment around backlogs, has dropped into theatre productivity and efficiency as being one of the key elements that we need to focus on. The letter clearly states some of the ranging statistics that are available up and down the country. And for us, theatre data was the last phase C of what we implemented in the eCare. So we were slower out of the starting blocks, and we have had some data quality issues in submitting the data. But we're on to that now and working through a fairly rapid improvement programme to get that corrected. Tim Briggs is coming to see the Trust on the 9th of December, and we will share the latest data with him at that point, and obviously where we are in terms of our productivity and efficiency. I think without going into huge detail now, hopefully a future agenda item that we can bring back post the visit. You know, our challenges are multifaceted, theatre productivity, from the workforce issues to actually the bed capacity. It's quite a complex picture to talk you through, but we'll have to bring you back through that. The letter does ask, obviously, that the board takes close scrutiny and reporting focus, so probably the general will be right time to bring that back post December visit. And there's an opportunity, obviously, for them to become associated with the work that's going on. I'm the senior accountable officer for this piece of work, and Dr. Hamid Manji, who's the divisional director of surgeries, is the lead.
I think it'll be interesting to get that perspective and bring the whole piece together. I think that'll be very useful.
I mean, I've never heard of it. I've been in the house for a long time, but I've not come across that. Is he coming in by invitation? Is he visiting all trusts? No. My words carefully. He's quite local. He lives in the Bedfordshire constituency, I think. But we are flagging in terms of our data quality issues. So he's coming to see us in Northampton. His first two ports of call on these.
Yeah, so I think this is part of the sort of wider piece of work. So the whole NHS has this new thing called SOF categories, which is system oversight framework. So trusts are sort of graded at different levels. And some of them by the NHS regions. Some of the things that are particularly important, like cancer reports and so on. There's this whole sort of amount of work going on between regions and providers, systems, to identify who's struggling and who needs help. This is the other arm of the NHS that needs to be sort of helpful and supportive, which is good. And GIRFT is quite a good thing, so it's brought data to clinical teams with an expert clinician. Starting orthopedics, which will be Tim Briggs as well. But they're sort of parallel working in both of those NHS and the stream.
You're an acronym, don't we?
Yes. Yes. Well, that's Hayden.
I guess it begs the question: what is our capped theatre utilisation rate?
I'd love to be able to give you that answer.
Yeah, and I can't give you a definitive answer at the moment, which is part of the reason for the visit. We haven't got our data structure set up to report accurately what the national data set is asking us to do. So I think we need to align ourselves with that. But I think room for improvement clearly. I am regularly reporting cancellations due to a multitude of reasons. Some of that was staff capacity.
Just a quick answer.
Oh, sorry.
I was late to it.
Oh, okay.
Which I'm not conscious you've not got the figure, but in terms of having figures on the policies, what's called that, where would this sit in priority of things in terms of, because we do get lots of data, lots of information. So what's your sense of?
So I, from a taxpayer perspective, clearly the NHS is really up against it, and we need to be making the best possible use of our elected facilities. So it's do better.
In terms of how big an issue it is, in terms of priorities of work, it should be on John's key stats report. Should we be talking about it about performance report, for example?
I think once we've got a figure that we understand and explain to everybody, then we should monitor it and work it well.
See whether it's a high one or a medium one, whatever.
In terms of recovery back
I was,
harm to patients, this is critical
Yeah.
in terms of looking at what we're doing to make sure we're maximising consent.
those kind of bang for bucks question.
Yeah.
Time.
So it may well be, quite high on what we look at.
It's high on one.
Page again.
Ian, I was just wondering if you could comment on that snippet I sent you last night.
So I was thinking about whether I would have a conversation with Hader, but so Hader raised something yesterday about day surgery rates and having seen some data outside the trust suggesting that this trust was very poor at that. We report internally on our day surgery rates, and our rates are very good, and I'll share with you the bread. I suspect the discrepancy, probably I need to understand your information sources, but I suspect the discrepancy is related to what we've just been discussing.
Be good to collect, because that was the NHS England that was posting that out. as a
Yeah.
actual data.
And we do need to understand, and that's good. It's very helpful that we've got that external overview as well, so that we can match the two up.
And we all recognise our data isn't where it needs to be, which is why Timber is coming to see us, it's all right. So
John, sorry, did you want to?
Well, I wouldn't want us to finish this conversation assuming that we were stupid or negligent in terms of our data. There are some very deep-rooted structural problems inside our computer system. So our data at an individual patient level actually is pretty good. What we have difficulty with is tying patients back to individual theatre sessions. So to know how well we use the theatre session, we have good information on individual patients. And that's something, and it's just how our system is built. We've spent the last 6 months or so probably looking into this, and I think we're only a few weeks away from sorting it out. But it is a proper structural issue, which has had a lot of attention and people's time looking at it, and it's not easy.
Can I just ask you a follow-up? John, is that because we're kind of pushing forward on a lot of the modules? We're one of the first to use this module? Or
So it's actually how the theatre system is built out, so that in good old days, outpatients clinics would have a unique identifier which says this is my outpatient clinic. The same would have been true of theatre lists. There would be something which clearly identified the owner of that list, when it's supposed to start, when it's supposed to stop. And that doesn't really happen inside CERN. So we're having to create artificial keys to create that so that we can then tie the patients back to that individual list. And so it's mostly, in terms of the efficiency, it's about how well you use that list, whether you have late starts, early finishes, whether you've overrun, and how often lists that are supposed to take place actually take place. And it's that sort of data that we are particularly watching.
so there are other people using the theatre module?
There are other people, not huge numbers, but there's a lot of manual work that's currently going on to report some of this. And for, I think it's fair to say, for a long time, we sort of ignored the requests for theatre data on the grounds that it wasn't compulsory to report it. And now it has become compulsory, we are catching up.
And again, it's important to be clear that Cerner isn't necessarily the root cause of this. We never had wonderful data before, so
No,
it was less interesting.
Almost none of us can remember that far back.
Final question on it then for me. So what are other people using that are getting the data?
So the majority of trustees don't use the theatre system that we use. They'll have a theatre system that is perhaps better able to report on data. The people who do have a variety of ways around it. And I think we have learned from the two of them about how to construct a theatre list in a way that we can give it a key.
Learning things. I'm sure there'll be conversations outside this meeting for those that are really into it. Thank you very much. Thanks for that. Okay. Right, on that basis, I think, thank you very much for the report. And I think we'll have our break now. Who's happy? Grab a drink. So we come back 1:45. Yeah.
Everybody take this code.
Yes.
That's insane.
Are we, we're still on, Louis, are we? For live? Lovely, thank you very much. And with, just before we go on, actually, I need to note, well spotted, number 10 on the agenda is missing. It's not that there's a missing paper, it's just that the numbering is gone askew. So, yeah, don't worry. Yeah. Just that we need to note that, so that nobody thinks we're in favour. Going on to item 15, then, the performance report, then.
Thank you, Alison. So just for the minutes and accuracy, we are reporting 55 escalation beds open today rather than Ian mentioned 33 earlier. We are including a ward that has been open all summer in those numbers. So I think just in terms of the external reporting and consistency, I just wanted to note that change. As Ian has referenced, incredibly busy, as the cover sheet 15.1 document in your IBABs, you can see across the various elements of the pathway how we are doing, and increased activity through September was going to happen based on the sort of holiday month of August, and knowing that we were going to get people back from leave and then people access services. So I think no surprises there, and a positive news story about the comparators looking back as we're being assessed to how did we do in 1920. In spite of all the challenges, we are reporting upward turns across all of the elements, again, of care in the hospital. The national focus very much is around the emergency department and the front door and ambulance handovers. And I'm pleased to report that we're still holding our own there. There's been quite a lot of dialogue in recent weeks, and again, more communication from the centre around your escalation plans and what we're doing. And we continue to revisit what we're doing in the department in terms of maintaining that ambulance handover. I was on a meeting with Mark Begley yesterday, and I mean, SCAS, we've talked about repeatedly before, got a good relationship, and in spite of their REAP level 4, which is similar to our OPAL level 4, their handover delays for us at Milton Keynes Hospital are very, very short compared to other pressures in the SCAS region. And I think there was a quote in the September dialogue between the region and ourselves around everybody had a 4-hour wait in an ambulance, and actually we haven't in MK because they didn't have the access to the SCAS data. So our longest wait in the month of September was 2 hours. Now 2 hours for a patient, again, would still be considered too long. But I was with colleagues in London, and 12 hours in ambulances is becoming regrettably seen across the country elsewhere. So I think we are managing to keep the front door safe. As Ian's mentioned, with the medical centre opening this week, huge success that gives us an opportunity now to reassess what we're doing in the ED department, and we are looking at the sort of expansion of some of the minors areas and provision because we've moved out the emergency surgical clinic. So again, we should see some better flows and experiences for patients in terms of progressing those developments as we get the staff in place to do that. So ED, as I say, at the moment, peer reviews compared to, as the paper describes, we're still holding around very much there, but it is a sliding national scale. And I think we'll have to be conscious of that and continue to work hard to sustain it for our local patients. Outpatient transformation, again, we're seeing more patients in clinics than we were in 1920. The two particular issues and the indicators that we look closely at in outpatients, the virtual clinic piece, which came into being in COVID, very much about how we access patients. We're still poorly reporting in that. So only 13.6% in September against a target of 25%. I think we have to still keep going around the houses about what patient groups and cohorts can be doing. And we're working with colleagues in other places where they've clearly got some pathways up and running, which we need to look at in terms of what we're doing here in Milton Keynes. Again, the DNA rate is 7.2%, very higher than we would anticipate. We need to continue. Ongoing theme, isn't there, in terms of communication, working through that. The elective recovery we've just talked about. Theatres, again, the active elective spells increased in September. We have still been challenged in month on the continuation of our theatre activity being resourced, supported and upward staffing to do the elective pathway given the availability of beds. I have cancelled routine work. I have managed to sustain the elective pathway for urgents and cancers in September, but it's becoming more difficult to do that, and
day surgery rates and all those things are being impacted upon keeping those flows going. We mentioned the number of patients we've got over 78 weeks. I suppose the point to highlight in reference to the earlier conversation, we've doubled the number of patients from April waiting over 52 weeks, and it's that far away coming behind that will obviously be the challenge moving to next year. So diagnostics again showing an improving trend. September actually we did experience both our new MRI machines or one refurbished MRI breaking down. And, you know, unforeseen difficulties, but inevitably we work those machines hard every day. We lose a couple of days, and the rebooking that then goes into that is that we're showing an upward trajectory on that. The inpatients work again. Just corrected the sort of number of escalation beds, and we need to be consistent with that because there are external pressures on the services, which inevitably is having an impact on other areas, but is also stretching our staff across the areas that we've got open. So yeah, I'm happy to pick up questions. We've mentioned the infection control issues on the embossment paper.
Thank you very much.
Specifics and HR workforce.
Yeah. Gary, then hey.
Less questions, Emma, just a few observations on what I'd find a little bit easier.
Yeah.
And we've collected a lot of data over 15 months, but most of the commentary is on month changes. And I would find it easier to have more visibility of what are the trends. Okay. And to set that in context, well, we should be seeing a trend and we're not. Well, we are seeing a trend where we're taking actions. And it's a bit difficult without commentary from you guys to set in context, just to set the numbers that are going up or going down, because are they going down less than they would have been? You know? So I think that would be quite helpful. What are the trends we should be focusing on? And you can kind of pull some out by looking at some of the numbers, but I think it would be much more helpful if they were wrapped around some commentary that said this is going in the direction I expect, or it's not going in the direction I expect. Two, so I'm not expecting a running commentary on what the key trends are at this moment, but two, we have comparison information, if I remember correctly, on the emergency units with peer groups. But is it only on emergency that we have comparable information with peer groups?
No, we've got access to other regional data. So within the region, I receive all sorts of reports on regional performance.
So is it correct that we only put the comparisons on emergency in this report?
It is correct that we've only ever done.
So it's changed over time. So historically, would have used Dr. Foster and other data sets to find some peer trusts, and that would have to make the stay and readmission and not much else. Right now, other data sources, much more transparency in the NHS, and we need to look at that again.
I'm just asking whether it's a good thing to look at the data.
Yes, I think it is.
That would be useful. And my last point, just a specific one, which has got me to Danielle. At 15.8, I was concerned that we'll probably want to talk about that, but I know we expected it to peak, but it's still a high number.
Sure. I was going to say, we'll pick that up with you, Dan. Yeah.
And just one thing, no one's asked me about it, and I didn't mention it earlier. There was a Never event in September, which I don't think we've discussed previously. It narrowly missed the cut-off that Tina's paper reviewed earlier on. So thankfully, it's a low or no harm Never event. It took place in August, was reported in September. But essentially, the incorrect patient ended up having an endoscopy. Now, the endoscopy itself, one could argue it was helpful because it found a diagnosis that otherwise wouldn't have been found, but the patient understandably is not happy that she would have an endoscopy not intended. Going back to it, it was essentially user error related to our Wicom's workflow in Cerner. We've done quite a lot of work looking at that. Essentially, a specific consultant's understanding of different terminology, cancer and reordering, cancer and reordering test. There's quite a lot of learning there.
Thank you very much. Ada.
I just wanted to say thank you so much for the summary. This was really helpful.
Yeah.
Understood the detail of the report so much better just by that narrative. So really big thanks there. Just a kind of minor question on the breakdown of superstranded DTOC criteria to reside. I'm presuming there must be you could have a patient that was both delayed transfer as well as super stranded, right?
Yeah, and non-criteria result.
And so there must be a, like, how do you figure out which group to put them in? And
So
Right, well, I think in essence now you probably could remove DTOC. They're not counting it nationally, and non-criteria to reside happens national benchmark of looking at medically fit patients in the hospital that shouldn't be here.
Got it.
The stranded and super stranded is more related to that length of stay. There'll be justification on some of those, but there won't be on all of them if they're not, if they are medically fit to be discharged.
So
there's a
super
subset
stranded
within
could still
is the
have a,
length of stay.
could still have a medical
Yes,
reason
yes.
to be here, but they're just here too long.
but they're all poor measures and to have something.
Yes, so
But and the no criteria to reside, those are the patients that don't have care organised somewhere else. We talk about social services and
Patients who theoretically could be looked at after outside the context of an acute hospital. That's theoretical.
So I suppose the good news in there is today, that non-criteria to reside is down to 68. I think. We've dropped that quite considerably. There's a mixed message in there. Some of the patients had been in there so long, they then became non-medical fit, so they relapsed and not appropriate for discharge. Social care in the last month have worked consistently harder to try and increase their provision in different areas where they were struggling to place their placements, and I think they've had some traction. So we've escalated with them. I know they're now having a daily meeting at 1 o'clock every day to access some of that. So yeah, the non-criteria to reside is probably, that's still 2 wards, isn't it, patients, we'd say.
do we have a discharge?
We have a discharge from
Yeah. I do. So I think it sort of links to that point, which is that it's the patients with a non-criteria to reside that I think I'm looking to, for us to say that are our focus, aren't they?
Yes.
With 55 escalation beds.
Yeah.
And nearly
Yes.
6 figures
Yes.
blocking those beds, and we have with our staff constraints.
Yeah.
We have to deal with
Yeah.
moving those people out. So it's not appropriate to have it, don't we? That's our
Yes.
focus, isn't it?
but reliant upon partners. Yeah.
So I'd agree with that. But one caveat is stranded and super stranded is black and white. So both basically haven't, whereas criteria for reside is an industry and somewhat subjective in terms of how they're categorised. So there's possibly benefits from both. Just back to Gary's point, I wonder if we should have an action by the end of the year with John, Emma and Hitesh to meet with any of the NEDs who are interested in order to inform what we might do with our metric next year. We need a medium time to redesign things.
No, agree.
I think that also fitting with the action where we are supposed to come back with something that's more accessible. It's one of those what is actually useful, so it does need some input on, but we'll come back with something which you may not find.
I was going to say, yeah, stakeholder involvement right from the beginning. Yeah. Great. I'm sure, Gary, you'll be one of those. involved.
Carry on.
Yeah, John and I. He's come to volunteers from his time.
Great. Good stuff. Okay, thank you very much. We'll move on then to item 16. Policy priorities.
This is very brief. You will remember that every year we have to set quality priorities that go in as part of our quality account. This year we tried to make them things that we were doing, that we were really focusing on as part of our core business, because sometimes they are quite fringe in terms of what they're focusing on. This year they are reduction in deep tissue injuries, improvements in elective care, so reducing long wait times, and reduction in discharge delays. I think I've just to sort of check in, I suppose, to ensure that the board feels that they're assured on those different areas.
Any questions? Thank you very much. Going on then to the finance report, Terry.
Thank you. So this is page 96 in the pack. Just conscious to a comment Bev made about front sheets earlier on. This says it has no report history, but the report was discussed at finance committee as you were present actually on Tuesday. In terms of the headlines of the report, so this is covering the period April through to September inclusive, so it's for that half year performance. Starting with the I&E position, we're reporting a deficit of 4.1 million, which is marginally behind the plan. You can see on that summary table on page 98. We continue to forecast break even for the end of the year, and that's a combination of things, including our planned profiles. We were always planning on delivering a deficit the first half of the year, and then recovering it in the second half of the year. And I'm happy to talk specifically if anybody wants a more in-depth conversation about that, but we're saying we're on track for the year and on the ID. Some pressures we have running through the cost base to start there. So we have a lot of the reasons that we touched upon in discussions today around possible industrial action and national pay settlements, as well as the business as usual vacancies and sickness that we've seen throughout the year. We have a lot of pay interventions that are overheating the pay position. So we put in, for example, things like enhanced bank payment rates. We will be extending our arrangements and practices for long line bookings with external agencies to make sure that we've got sufficient numbers of staff in the building to meet needs. But that is providing us with a pay position that we wouldn't in any normal year be able to afford to carry, given the level that we are funded at for pay. So that's a pressure that we're seeing. We've also clearly spent a lot more on pay to tackle things like the elective care backlog this year, and we do get funded for that to a reasonable extent through the elective recovery funding. But we had a conversation at the Finance Committee earlier this week just to keep a rolling eye on that pay position, particularly because of some of the downstream interventions we have, for instance, international nursing recruitment, some of our domestic recruitment plans to make sure that we're weaning that position back, with all the variables that sit within there. Staying on the cost-based position, so when we look at the non-pay, you can see that we're delivering broadly to budget for the first half of the year. Hidden within that has been quite a bit of turbulence around the inflationary pressures that we're seeing for things like contracts and consumables that we buy in. I think it's a sort of general but fair comment that for the first half of the year we haven't seen the cost burden coming through that we had feared may have been the case on inflation, but we have had protections for contracts that were signed prior to the big peaks that we're seeing in inflation, up at sort of 9–10+%. So we are expecting that to be quite turbulent between now and the end of the year. It's wickedly tricky to forecast that because you are literally doing scenarios on contract rises, and they will vary between catering and laundry suppliers compared to people that provide the clinical consumables. So there's a lot of work going on both within this organisation and regionally and nationally to try and get a grip on that. But that's going to be quite busy, I think, between now and the end of the year. On the income side, so I think in the last month's meeting, it was probably updated from Daphne that NHS England has decided to underwrite the amounts in the plan for the elective recovery fund. And I think that's a sensible decision, a pragmatic decision, and one that will probably serve the vast majority of providers well. Selfishly, and looking entirely through a local lens here, when we look at our relative performance to peers for how much of the recovery we are delivering compared to 19–20 activity levels, we are typically top 2, top 3 in the region in terms of strength of performance. So we think that isn't rewarding the relative performance of the organisation because it's literally underwriting the planned levels of performance for elective recovery funding. We're lobbying and working with NHS England to try and see what can be done flexibly around that. You may recall those of us that were here when we signed off the annual business plan earlier this year. We were responsible, but nonetheless bold in the amount of investment we put into additional capacity, outsourcing arrangements to try and maximise the throughput of activity. We can certainly sustain that for this year. But unless that policy change is going forward, I think there's a conversation we want to bring back to see what the affordability trade-off within that position becomes. We had a bit of a conversation about that at the Finance Committee on Tuesday. Other things just to call out. So we received funding for the National Pay Award in September. For the whole year, we're going to get an extra funding injection of about £4.1 million. We think that is going to leave a residual pressure that entirely depends upon the seniority that we recruit into for some of our vacant posts. So, for example, the national funding is paid at the lower scale range within certain agenda for change bands, because that's the policy decision. If we recruit very experienced people, there is then a residual pressure that comes through. So we'll be monitoring that quite closely, particularly as we onboard more people. Other things to reflect upon. So there's a good piece of work that's been kicking off over the last month or so around the forecast of the organisation. There's been good bottom-up discussions with clinical leadership, divisional management teams and colleagues that run corporate functions. We had a discussion in the Finance Committee on Tuesday, just getting into that. We're working back from a range around the outturn, and we'll bring that position through to committee when we've got a bit of a sort of tighter grip around the outturn. That's not unusual. So typically, work around the precise makeup of the forecast really intensifies in the second half of the year. So we think we're relatively well placed. One of the main focuses on that, particularly given some of the national sort of macroeconomic challenges we're facing, is what we think the run rate of the organisation, the cost base of the organisation looks like as we exit this financial year and going into next. We know there's a big statement coming on the 17th of November from the Chancellor. There will be some clearly, implications and consequences from that, I'm sure, for the NHS funding position for next year. So we're already starting just to provide some assurance, our homework on that. From a cash position, we're again well placed, so there's no immediate concern. We've been having good conversations with our outsourced supplier, SBS, so Shared Business Services, around the timeliness of invoice payments. We did see some slippage in our payment performance, so we're supposed to pay set percentage, 95% of invoices within 30 days of receipt. That had slipped largely because of an onshoring exercise that provider did during COVID, and there was a training lag for some of their teams onshore, which created a backlog. Bit of a theme for this year in the NHS. They've worked their way through a good proportion of that backlog, and myself and a member of my team have got a conversation with them on the 11th of November just to see that that's now coming back into a sort of steady state positions. But we're encouraged so far, but there's a bit more to go. On the capital front, we spent 5.7 million of around about a 6 million plan at the halfway stage of this year. We need to spend, you can see in the report there, about 17 million by the end of the year. So there's quite an uptick in the pace of our capital outlay in the second half of the year. Similar to the work that's been going on forecasting for the revenue side, there is a piece of work looking in great detail around capital spending plans, working closely with local scheme leads for not just the big schemes, but also that long tail of smaller individual value schemes, and that continues. Again, so just a final point, we've started work already looking forward towards the year end, and an assessment of liabilities and things on the balance sheet, recognising we have the audit team coming in this year, and there's a good bit of preparatory work we want to do with them to get them familiar with the finances of Milton Keynes before we go into the new calendar year, because that's quite an uphill exercise if you're coming in as a new audit team to a fresh organisation, looking at everything for the first time in the last few weeks of the year.
Thank you, Terry. Any questions? I know we did go over this at the Finance Committee on Monday. Gary.
So not so much a question, just an observation. I just want to say, I think it's really important what you do, Terry, on the run rate, and draw people's attention to the fact that our cash balance reduces by about 20 million this year, something like that. And obviously some of that's capital, but some of it's the fact that we're using some of the money for some of the activities we're doing this year. So understanding what we're really running at, when we exit this year and move into next year, and getting ahead of the game on that is really important, because it will inform conversations that we need to have up with, and also in terms, I think that's quite key. And then a very specific point, Terry, what was the reason why we were 3 million out with cash this month? Was it the pay award coming out that we didn't?
Yeah, so we've obviously been paying people the backdated pay award in September that was inactive.
And you didn't have that in
Yeah, correct, for April. Okay. So there's 6 months there.
Right.
That looks like it goes out as a big lump. And then,
and that's why we're 3 million out in the month.
Yeah, correct. And your point is exactly around the cash, and there is a significant outlay on the capital scheme, but I think a key line of sight on that working capital balance and how that ties in with the INE and the capital commitments in the balance sheet is a good bit of work to bring into the Finance Committee next month.
Thank you very much. Okay, thank you. Thanks for that, Terry. Going on then to workforce report. Yeah.
Thank you. I'll take the report of Ren and just pull out some key things. So our vacancy rate is slightly over 10%, and as we've already alluded to, our retention rate is not, the turnover rate is not coming down yet. It's not going up either though, which is good. When we compare ourselves with others in the ICS, we're actually doing better than our neighbours, but still it's not where we want to be.
There's lots of work and interventions the team have been doing over recent weeks in regards to that, and that stems from everything from trust-wide, such as introducing a new exit interview process, through to individual meetings with teams, departments, talking about generally what's happening, what they feel at listening events, both in areas where we've got specific concerns, but also just generally as a result of the staff survey work that we do every year. We continue to do interventions as they come forwards, but we find that a lot of the reasons people are leaving are things like work-life balance, retirement, going somewhere else for promotion. I think when we talk to people that generally haven't taken their next job step in the last 2 years, they've stayed where they are during COVID, and now COVID's come to an end, they're just starting to think about their next move, whether that be here or somewhere else. Couple that with people who are leaving for retirement, because it's the last few years have been hard and they're looking at the winter that's coming. I think the work we're doing will start to make a difference. However, if I'm honest, I won't expect that to go down over the next 3 months or so, simply because I know that we're coming up to a period where people in the band 2, band 3 brackets can get work elsewhere for the Christmas rush, which is more appealing to them. And we know that we've seen in previous years, they leave, they go to Amazon, they go to John Lewis, they get the £1,000 sign-on bonus, they stay till after Christmas, then they come back to us. And I think we will see that happen again this year more than ever. So whilst I think we will, I'm hoping we're coming to the end of the people leaving, taking their next job step. I think we will then start the wave of people going to work at the big warehouses and then coming back again in the early next year. Of course, we do everything we can to discourage people from doing that and encourage them to stay with us. But I think this year those £1,000 sign-on bonuses will be more appealing than ever to people. Having said that, we did the MK Job Show, and there's some pictures in the pack of our stand at the MK Job Show. It was the busiest it's ever been. We've never seen that many people come through, and we had lots of interest even from staff groups that we wouldn't usually expect to see interest from at a job fair. So qualified nurses, pharmacists, physios expressing a wish to want to come and join us here at MK because they've heard that we're a great place to come and work for. So that's really positive. The team in recruitment, we see that coming through bearing fruit because the team in recruitment are actually really, really busy. We've got between 300 and 400 people in having had job offers made, we're clearing them or are working their notice at the moment. So we knew we were very busy with recruitment over the summer, and that is showing the number of people that we're coming out with the onboarding process for. Statutory mandatory training, we're traditionally good here, touch wood with statutory mandatory training. We managed to stay above target both for that and appraisals, and that continues, even though we've introduced some more mandatory courses in recent months. You'll all have done the Freedom to Speak Up courses. There's been some other courses on there around conflict resolution. So lots and lots of people have been doing lots and lots of training, which is good. But even now, when they've come through on the mandatory numbers, because we have a grace period for people to become compliant before we start to report on it, we're still managing to maintain above our target, which is good news. We are, Terry already alluded to the fact that we have agreed a second tranche of international nurses. So thank you to the Finance Committee for approving that business case, and we're working hard to get those nurses in. We've recruited the first tranche for 125, and we're working to get them through their OSCEs. And thank you to Yvonne for going through our process and with us. And it's always great to have an external pair of eyes on it, or internal now. We're making a few tweaks which should hopefully help us with our OSCE pass rate, especially as we're going to be getting another 100 colleagues from overseas, which is good news. The Work Any Hours campaign is launched, which is a really positive thing. So that's allowing people to say, I want to come work for you, but I can only do Monday 10 till 2 or so what we will do is work with people to say, what hours can you do? At the beginning, we're going to put them in a pool of sort of flexi pools, so we can allocate them on the day. But longer term, we're looking to see if there's a way that we can let those people choose which wards, but that's a challenge for rostering. So we're just starting off slowly and seeing where that goes. We started off with the nursing workforce, but we want to expand that to all of the workforce. We're thinking particularly, we know we've had a lot of people retire over COVID. They might not want to come back and do a full-time role. But actually, if we can tempt them back to do 1 shift a week across all the different staff groups, that will make a difference. So we're working through that. Ian, in his update, talked about the Protect and Reflect event. We've been running that now for a little over 4 weeks. We've been fully booked pretty much right up until this week, where we've seen numbers tail off a little bit. It's running here. We really like people to come here to have their staff do their staff survey and have their jab, because it gives them an opportunity to have a sit down and a break, and gives them a way to take time out. Recognise that's not been possible for everyone, so that Reflect and Protect event goes mobile from this week. So we split the team in half stay here and half are going around to the wards and departments. We've got time scheduled in each one, so we should start to see another spike in our flu and staff survey returns. Equality and diversity and inclusion, we took the latest Res and Des to Workforce Committee in the last couple of weeks, and we'll bring that Thomas Dunkley, who is our head of HR business partnering, is going to bring a presentation to board similar to one we had previously, to give an update on this year's numbers. But it's positive. We're making strides forwards, which is good. We're going in the right direction. And we did have Black History Month, and we did a special menu in the restaurant for Diwali as well. And then last thing for me is we did the good at the end of the summer. You recall in previous years, this was a bit of a pick me up for the going into the winter and the autumn. We take goodie bags around all the wards with like cakes and chocolates and fruit, and fruit is very important to have in as well. So cakes, chocolate and fruit, and the wards are really appreciative of that this year. And we are just staff generally we're pleased to receive that, and hopefully that will go down well. So yeah, that's my thing.
Two things. I love Protect and Reflect. That was brilliant. Whoever came up with that. That was just one comment. On the international nurses, do we lock them in any way? Is there any sort of?
We can't do contracts which say you must stay for so long. We can't do that, but we sponsor them for their visas and what have you. And we tend to find actually that the international recruits stay longer than the domestic recruits. Partly, I think, because we build a community. From a just thinking about it from a personal level, they're moving into a brand new country. They don't know anyone. They feel real attachment to the organisation that sponsors them, and because we do such a large amount of pastoral work with them, so when people first arrive here, we have to take them to a certain bank to help them get a bank account and all of the outside of work. So we tend to find actually, although we can't tie them in, the international nurses do stay longer. The challenge for us now, as we'll have about 250 of them, is to help with the career progression. So once we get over the initial, this is what it's like to be in the NHS, this is what it's like to be in the UK, it's how do we then help them with their next steps in their careers?
I've had a few conversations with Joe over the years, when I was at the university, around the trust wanting to be an employer of choice. I just wondered what else we're doing. Obviously, it's great to be at the job show, but what else are we doing in terms of outreach to different communities and obviously future pipeline of talent to help them to see the hospital as an employer of choice?
Yeah, so our ED&I team, I don't know if you've had a chance to meet Idris yet, our ED&I lead, he spends a lot of time out talking to different communities around MK, the different faith groups, different community groups, highlighting, raising the profile of the hospital from both a staff perspective and a patient perspective. So he's been in post about a year now, and he's starting to make some real strides forwards, which is really good. We have a really active education team who go out and do lots of work with schools. and the different colleges, far more than any other trust that I've ever worked at. We still have a really active work experience programme here, for instance, that is open to everyone, and we get a really good mix of people on that. So not just people who want to be doctors, but people who want to be physios and pharmacists and healthcare support workers and midwives. So a really good mix from lots of different communities and different groups. So we do a lot of that. We still need to do more. And we'll welcome help from anyone around how we get into the different communities that we might not have contacts with at the moment. We're working on talent management strategy, but also talent management strategy, particularly focused on groups with protected characteristics, whether that's BAME colleagues or colleagues with a disability, because we know that we need to do more to help certain groups see us as an employer, and also help them see how we can help them with training, how we can onboard them, how they would fit here. So we're doing lots of work around that, but as always, happy for any help people might want to give in that regard.
Thank you. Thanks very much. Just one quick one from me, Danielle, and this is just stuff I picked up recently now that I'm doing the maternity champion thing, but I was interested to hear apparently in Bedfordshire hospitals, I think they've, in the maternity section, they've now got 25 overseas nurses who have come in and got their PIN numbers from the Nursing and Midwifery Council. Have we got a link in with them to see what they're doing and whether we can piggyback?
Yeah, so there was a national programme of work around bringing in international nurses in maternity. We took I think we went for a very small number because it was new. We were just doing international nurses as well for the first time, so that was still new. Keen to do more this year, whether through the national programme or through our own agency that we use abroad. And yes, I attend lots and lots of meetings with my counterparts across the whole of the ICS. Was just talking yesterday, in fact, with Bedford, one of the councils from Bedford, around whether we could do some joint international recruitment with social care, for instance, because they've got some practices who maybe want one or two people. It's industrial scale that we do. They need help with that. So with lots of work around the ICS around how we work together more as well.
Can I just be clear for the minutes whether we're talking about nurses in maternity or midwives? We're talking about midwives.
Yes.
Sorry. Yeah.
There are nurses in maternity.
Yeah, no, that's true. Yeah, no, that's absolutely right. Okay, thank you very much. Okay, thank you. Going on then to freedom to speak up. Danielle, are you covering that?
I'm going to take it. Unfortunately, Philip can't be with us today because he's had a bereavement. So our thoughts go out to Philip, and I'm going to take his report for him. So we've been doing a lot of work around freedom to speak up across the trust in the recent weeks and months, really highlighting the Freedom to Speak Up team. As I spoke to earlier, we've now mandated all the Freedom to Speak Up training. There's 3 different levels of that. There's one for everyone, one for managers or people who might be spoken up to, and then one for the board, which hopefully everyone has done on following up. There's still more work to do. We know that we still don't have quite as many freedom to speak up things raised through that route as perhaps other trusts do. So we're working hard to raise the profile and encourage everyone to speak up about anything that they want to. Philip's provided in the report a short overview of the concerns that have been raised this year, and described briefly the structure of the team here. So we have Freedom to Speak Up Guardians. There's a number of those, of which Philip is the lead. I've been helping and supporting those. We have champions in multiple areas that people can go to. And the role of the Freedom to Speak Up team is really, it's twofold. One is to make sure that people have an avenue for anything that they want to raise that they don't feel comfortable or able to raise through another route, and to make sure that gets heard by the appropriate people. And Philip and team will either bring that forwards themselves and support people to come and see myself and other directors around things they want to share, or we'll help people signpost them to the right areas. So for instance, the Freedom to Speak Up team wouldn't be expected to deal with payroll queries, but they still get some occasionally. So signpost those to the right area, or help and facilitate the colleagues to go and talk to people, their own line manager, if they don't feel able to do that. So lots of work going on. That goes in hand with our existing support services. So there's things like peer-to-peer that people can access as well. which is another way for people to be heard and listen. We had an audit this year, so thank you to the audit team for taking time to do that with Philip and myself and Louise Clayton, my deputy. And out of that, it was highlighted that we just need a little bit more double checking on figures before we submit them, to make sure that the what's reported matches the local tracker we've got. So Philip's put a process in place to make sure that happens going forwards. It was highlighted that we really should bring the report to board twice a year, not once a year as we've been doing, because that's the purpose of this mid-year report. And Nikki and I are going through the Freedom to Speak Up self-assessment tool for board, which should be done regularly. We last did it in 2019. We're redoing it again now. There's been a new version published, and we'll bring that forward as we do that. Policy was reviewed and resubmitted, and a major coup for us was that we managed to get the National Freedom to Speak Up Guardian to attend an event in the Thames, which was really good. She gave a really good presentation. I spent a lot of time with the team. Thought the work we were doing actually was really positive, and gave us a few pointers on other things we could do, which was very helpful. Philip and team continue to be well integrated into the local networks, so they've got lots of ways, either locally or nationally, if they need support, they can go to get that, and lots of shared learning through that. And the team are, as I say, just out and about all the time, raising the profile and doing everything they can to make staff aware of who Freedom to Speak Up are, what they are, and help staff in any way that they can.
Thank you, Danielle. Lots of good work. I was especially interested to see the web-based form. Is that anonymous? Can people now kind of raise? I know, it's not as helpful because we can't dive into details, but
yeah. So there's lots of different routes, and we've so they can do it anonymously on the form. They can put their name on the form. They can call. We do have people ring and leave voice messages just on the mobile phone. People can email. We've got suggestion boxes. People can drop things in and either write their name or not. And Philip brought an app to the attention of the exec team recently, and we agreed that we give that a year pilot as well. So we'll put that in soon as well. So that's another. We just want to make sure we've got lots of different avenues and routes, because a bit with everything, one size doesn't fit all, so we need to make sure there's something for everybody.
I think I'm hopeful that with the app we might get the same response we had with the feedback from patients when they use the app on their experiences. So fingers crossed we might get the same input.
Heidi, it's only a quick question. How do we decide what's the right size of guardians and champions?
Very good question. So at the moment, we are trying to make sure that we've got good representation from across the whole trust. So one thing I forgot to say is we've asked each of the staff networks if their deputy network chair would be a guardian as well, because we find that the networks are actually dealing with a lot of issues that the guardians in other trusts would deal with. Because we've got such advanced and well-functioning networks here, the networks are actually picking up a lot of that as well. So what we're focusing on at the moment is making sure that there's someone who everyone can relate to if they want to come forward with something. Whether that's too many or not, we don't know. But I think we'll just keep reflecting back on it, and if we feel it's too many in the future, then work out what next to do.
I think one of the key things, because I attend the meetings, and also is that around whether, even if people aren't guardians, the whole idea of champions, so that you could have as many as you want really around the organisation, because people will then be talking about it, which will be a real plus.
I think so. About the accessibility.
Yeah,
and also we know that if someone can talk to someone quite soon, usually things are dealt with in a better.
Yeah, absolutely. So it's almost like a sort of a formal setup with a guardian role, and but in parallel, all those sort of slightly more informal ones where you've got lots of champions around the organisation. So hopefully we'll get hundreds and hundreds. Thank you very much. Thanks for that. Going on then to the significant risk register.
Just here for any, I'll take it as read here for any questions or comments. Back isn't here because it's being redeveloped. It's on the part 2 agenda.
Yeah.
But it's a slightly different report this time. There's some shows some movement between 2 months and reporting. Otherwise,
Thank you. I suppose it's worth noting that although the VAT's not come here, the normal review of risks is carried on through the committee.
I was just curious around 382 and 388. What were the difference in those two new risks? And isn't the exit either big enough or not big enough?
I think that could possibly sit across 2 different areas. That might be why it's on twice. It shouldn't be there. It might just be an error, so I'll double check. So I haven't been there myself, but I think the health and safety manager's gone and assessed it, and the fire officer have gone and assessed it. And their view is that it's not ideal, but it's on events. So yeah, it's.
Maybe we could take that outside, perhaps.
So it's worth discussing about that in executive week.
Yeah.
I think it would mean so obviously those patients are not that. So there's a contingency plan in place around how it would operate. I know the fire officer and the health and safety manager have been helped assess it. So there is a contingency plan attached, which is not part of this.
Get some assurance on it, please. Yeah. Any other questions? Hey there.
Thanks. Okay, thank you also for the summary report. I still find the actual log to be fairly unreadable. But just so 2 questions, the indicators. Remember we talked about symbols before and you said it was a printing problem. This was on a different one, but I just wondered if this is the same thing because I don't. Are they meant to be ticks or something as well?
I don't know what the indicator symbols put on here are. No, what they
Good.
mean.
Well, at least I'm not being stupid.
It's not you. I don't know where they come from. There's no. So
Cool. And then I was the risk 001. Just being a nerd, is the first risk that was reported on radar, presumably. I'm just wondering why it like shows as a new risk.
sorry, when
So the new risks, there are 4 new risks, and risk 001 is if you don't report stuff on radar, then we won't be able to action it. Feels like that was Paul's first risk when radar was set up. I mean, you don't go backwards in numbers, right? You just, anyway, it's just that
that's been a risk, so it's not a new risk, it's might be it's
newly escalated ice.
Yeah.
So what the
It may be the data specific risk of radar.
Radar, yeah.
But that's gone up because people aren't reporting.
It's got up because of the system change. Yeah. So I think that's all that is. It's been a long, so the lack of not something not being reported has been a risk for a long time. It will always be a risk. But I think it's been changed to reflect the change to radar and the LPSC.
Do you want to have a bigger discussion outside the meeting, maybe, just to understand it a bit better?
I think we just need clarity, don't we, as to what for new significant risks mean. What new, sorry.
What new means, yeah. Yeah.
New,
yeah. Maybe we can pick that up outside. Any other questions?
Just a quick one for me. This is being, you're re-looking at this climate change, this significant risk.
Not really significant risk, Winston. There's a significant risk.
Sorry, go on.
Sorry, I mean the significant risk register is a pull from the risk management system. Because for me, it would be this front sheet would be could be improved in terms of looking at our appetite for risk. Have we got more risk in? It's not just the number of risk, the level of risk, and also think about how you break that down, because some things are coming on and some things are going off. So is the trust in a riskier position than it was? What's the trend on risk? So we're resolving risk. So I think that more of an overview would be helpful,
because I do take Hayden's point about the detailed risk ratio, but from our perspective, Hayden, I think that more holistic position of is the trust in a riskier position, what's happening to that is for me would be more useful than going into any one specific risk.
That's right. Yeah, you're right. We do need to produce it. In fact, it probably needs to be kept as an action due the risk sort of overview pack, so that we've done a bit, so risk profiling across the organisation plus.
You know, which areas are going up? Is there more risk in some areas than others? You know, and all those kind of traditional trend data you'd get into.
Yeah, that's helpful. Okay, so we can have that sort of overview introduced. That'd be good. Okay, thank you very much. Right, going on to 21. Summary, these are the board subcommittees. I don't intend to go through each one separately. They're here for everybody to note. Unless there's any extra comments that anybody needs to make. Yeah. Okay, so those are noted. Thank you very much. And also on 22, terms of reference for the board subcommittees. Now, these have all been through the various committees, so hopefully colleagues have commented and the members have been made. If there's any last minute things people think we've missed. Oh, yeah.
So I'm very much speaking the medical director hat on rather than acting as Joe.
Yeah.
I'm a man under enormous demand for this committee. I've been added onto audit committee.
Yeah.
I'd like to understand what's been outside the room, but we'd like to understand what Carrie's trying to achieve, because I think as a medical director as a role, I'm more interested in meetings than the acting medical director. I just want to understand what you're trying to achieve, but maybe outside.
No, so I can kind of answer that now. So actually, I also went and read this again, thought, that's a lot of demand on its time.
Obviously understandable.
Yeah. But I think it was more about input on key medical issues. It doesn't necessarily need to be you, Ian. So I think it's more about having the right kind of representation on the audit committee so that the medical dimensions of lots of the risks that we're looking at are completely understood. So it wasn't a specific request for yourself, so that could be reworded.
So that was to be down to clinical rather than medical.
Oh, well, I'm not sure I completely understand the difference.
But nursing or therapist.
So that's probably what the comments I have is that we're missing there as well.
Yeah.
Right. Can we reserve that one?
So I think we can deal with it in a different way rather than having use on the committee. Is my point.
Yeah. Okay. And look at you're right. Medical clinical dynamic.
So if we can just reserve the audit one. So to further conversation with Joe, then we'll come back to Gary.
I think that's
going to be.
Yeah, great. And it'd be helpful to have that sort of whole approach, the perspective. Great. Okay, so subject to that, everybody's happy and we can approve those. Thank you. The forward agenda planner, any comments on that? I think that's fairly self-explanatory. Thank you. Questions from members of the public. I haven't received anything, so unless there's something hiding in the wings, that's just noted on this occasion. And it just brings me to bring motion to close the meeting. There's one in public, and we'll have a short break. I think we're going into remuneration committee if we can, just quickly in the lunch break. That's for myself and non-exec colleagues. And then we will start the second part in private. What's the time now? 22. We normally have half an hour, so don't we? So 1:15. Is that too quick? 1:15?
Like a lunch order, so we can certainly get you.
Now there's
that's a key.
Yeah.
Now for remuneration.
Remuneration. We thought we'd do it now. Yeah. Guess it
For the private session.
That's right. Yeah, we'll note that. Thanks, Heidi. So thank you all very much. Thank you for your time and thank you for all the questions and comments. I think it's been very productive today.
Anybody wants a sandwich?
Don't come to a meeting that they're doing.
Can do, yeah, I think there should be.